This is Cheryl's number. Okay, and then I'll just let her know. Yes. Cheryl is having to call in for some reason. She's able to get through on her phone, but not on her regular.
Morning, everyone. We are just delayed a few minutes waiting for folks to join us.
There's no water in this machine. There's a cup of coffee. I got a pod, but there's no water in the machine.
So would you like me to go run and get that fixed right now, or?
No, I tried the kitchen.
I actually tried before you.
Oh, no, it's very helpful.
Yeah, they're not.
We don't have anything to do with that meeting.
I will take care of it.
That's okay.
Can I go out and get coffee?
I know.
I'm sorry.
I said I got the pod. Is that
She's here, but she's able to speak. Can she hear us? Okay. Oh, but she can't speak. Okay, well, let's get started, everyone. Good morning. Welcome to the August meeting of the Universal Health Plan Governance Board. Let's get started with a roll call.
Helen Belanca,
Here.
Chun-Wei Chi,
Here.
Amy Fellows, here. Michelle Glass.
Here.
Oh, I see you, but we didn't hear you. She's muted.
Here. Can
We're
you
not
hear me?
hearing you, but I can hear you. We don't have our line. We try again, Michelle?
I'm trying again. I'm here. Good morning.
We're not hearing you.
Do we have any other board members we can ask online that we can get to speak? I don't see any.
Michelle, can we try one more time? They can hear
Oh,
online, so I
okay.
have something.
Thanks,
on the line.
Morgan.
Thank you, Morgan. Good morning. Michelle Glass. I am present.
There we go. Oh, there we hear you.
Okay.
Thanks, Michelle.
Okay, great.
Chris Goldberg.
He's not going to be here today.
right? He's in Connecticut.
Judy Richardson here. Thank you. Cheryl Ramirez, I see that you're here. I know that we are having some tech issues for you, so present for Cheryl. Mary Lou Heinrich here. Thank you.
Great. So for our meeting today, we are going to do some business with our executive director report, and then the bulk of our meeting is going to be spent with our consultant, Morgan from Echo Northwest, who's going to talk about the revenue strategy that he's been working on with our Finance and Revenue Committee. I think that'll take up most of the morning. And then after our break, we'll have a brief discussion about the role of regional entities. And then our committee updates. We have one straw proposal to consider from Plan Design and Expenditures about provider reimbursement. And then possibly, if we have time, some federal and state policy updates. So with that, let's get started. As always, the board is grateful to the members of the public who took the time to write in to comment on our work. This month, we heard from Eugenio Garcia, who expressed general support for our work. We heard from Lou Sinninger, who advised us to keep provider payments simple and to limit the role of regional entities. He advised sticking with fee-for-service for provider payments and encouraged us to consider how emergency transportation will be covered. He also advised us to reach out to unions as an important partner. Bruce Thompson sent us an article from a Eugene Springfield media source about continuing problems related to Optum's acquisition of Oregon Medical Group, despite recent legislation about the corporate practice of medicine. Robbie Cox and Tressa Cox both wrote in to say that they oppose a universal health plan and any increases in taxes and feel that everyone should cover their health care on their own. Brittany Gert wrote in to oppose a universal health plan, saying it is unfair for Oregon citizens to be taxed to pay for health care for non-citizens. Linda Krieger, apologies for the pronunciation, wrote to oppose the income tax credit, which would be given to individual taxpayers to compensate for the payroll tax their employer paid. We'll be hearing more about that during Morgan's presentation. She argues it is not a double tax since there are other payroll taxes that are not compensated in this way. And she says if the credit were applied, everyone's tax rate would be higher to compensate for the lost revenue. I encourage all the board members to read her testimony before we make any decisions about our revenue strategy. She said that the payroll tax should be considered the employer's contribution and not a payment on behalf of the employee. She also disagreed with some of the information on Morgan's slides, and we sent those comments directly to him for his consideration. And that's all of our written public comment. So at this point, I'll hand it over to Mimi for the executive director report.
Thank you. All right. Oh, minutes? Oh, so sorry. I missed an agenda item. I apologize. Let's take a moment right now to approve the board meeting minutes from our July meeting. Is there a motion to approve the minutes? So moved. Is there a second? Yeah. Any discussion? Great, let's do a roll call vote.
Ellen Belanca,
Yes.
Chun-Wei Chi,
Yes.
Amy Fellows,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg, absent, Judy Richardson.
Yes.
Cheryl Ramirez,
Unable to, she can text. If you want to text me, you're yes.
and Mary Lou.
Yes.
Great. Motion passes. And then I already checked with Isabel. We do not have any public comment on voting topics today. So we can pass that agenda item. And now, sorry, Mimi, moving on to the executive director report.
No problem. Thank you. Next slide. So just a few updates about what's going on. Happy to say that in terms of our consultant groups, we're now at 100%. All the consultant groups are on board, which is terrific. And Millen has definitely hit the ground running. We're doing a lot of work. So what that has led to is increased progress on all of the work plan deliverables. So we anticipate more and more proposals coming before the board in the next couple months. So happy to have people get ready for that. The staff here have created the outline of our final report format, and we'll be presenting that as it's further readied. Also starting preparations for a legislative report that's due in 2025. There are a lot of updates that are happening to our website courtesy of Isabel and also the DCBS Marcom staff. Just to make it more accessible, to make some of the things a little bit more clear, to remove some of the outdated references. So I'm really grateful for that. In addition, as I mentioned, that we have new consultant groups on board. I'm happy to report that we have a new consultant group that is able to do simultaneous interpreting, which we have had for the CECC meetings, but our prior group has not been able to keep serving us. So we have another group on board for the CECC meetings, and starting next month, they will also be available for our board meetings. So simultaneous interpretation in Spanish will be available. And then lastly, I just put the initials HMA because our beloved HMA consultant group, their contract ends at the end of this month. And I cannot express how much they have, just even in my short time that I've been here, but all the work that they have done and have helped move the work of this board forward. So a huge thank you to Janine and Anya. So that was, those were the main updates, and we can go next. This is the budget report. This is the final report of our last biennium. There's nothing really different from what we talked about before. As we mentioned, professional services was the area where services and supplies where that was underspent more than anticipated, just because of delays in getting some of the groups on board. So total expenditure was very well under budget to the tune of approximately $850,000. And as soon as we have the legislatively approved budget, which certainly will be here before the next board meeting, we will talk about that and go over it a little bit more thoroughly with the line items on our budget. Yes.
I guess I just have to voice my concern again. I've said it before, that it's not you and me or the people sitting in this room, but it is very disturbing to me that we left over $800,000 of this important work unspent. And I know there were reasons and whatever, but I just have to say, from my experience in governmental budgeting, it's a tragedy. And we can't carry that forward. So, still milk it. This one. Thank you.
And that was what I had for my report. Any other questions? Oh, okay, so yeah, next, so this is a new item this went out to people, so this is about excuse me, for a new procedure for adding committee members. So as you know, and for those of you who are online, it is an attachment. And for those of you who are here in person, it should say policy and procedure, policy number 4, committee member addition procedure. So I hope you've had a chance to read it. What the gist of it is that the addition of a new committee member is at the discretion of the committee chairs. So that is one thing to know, because certainly some of the committees have had people move off and haven't necessarily added a new person. So it's at the discretion of the chair, and because the UHPGB received many applications, and those are still available. The procedure that we are proposing is that the committee chair and committee board members who are on that committee will review any of the applications that have been received in the past and select the top applicants. Staff will reach out to their applicants to see if those people are still available and interested. And then the committee chair will then, if the answer is yes, the committee chair will present to the board that applicant for a final decision by the board. If no current applicant is available, then we'll have an open process similar to what happened previously. Yes.
I don't believe that the board was involved in selecting the original committee.
Yes, Lori?
Okay, all right.
I voted on them all.
I
We had a
voted on
meeting
that.
where we ran through all the names.
Oh,
and we're on board.
Okay, thank you for your question.
Yes, I just have a question. I understand with your explanation, et cetera, but it just says committee members are added at the discretion of the committee chairs. I understand what you mean is that the decision whether we need to fill a committee position is at the discretion. Is that what that means?
Yes.
Okay, so.
Yes, if you think, you don't have to come up with it now, but if you think of a phrase or a way to state that, or we can work on it too. You just like that to be a little bit clarified.
At their discretion, they decide, but then you go into that they really don't decide. Decides.
Oh, you're saying that it sounds like the committee chair.
I understand.
At their
Okay.
discretion, they add a person or
Okay.
not, and it's like, I know that's not the intent.
How about to nominate? It's at the discretion of the committee chair to
Exactly.
nominate a new member.
Right.
And then the board approves them.
Okay.
That's a good compliment. Yeah.
All right. Yes.
So I just want to clarify, the only pool are people who have already applied, but there's no opportunity for like new people who maybe are
So
really engaged in following our work to apply.
not necessarily, so that in the initial outreach is to people who are already applied and chosen by the chairs and are still interested. So if there is no one in that category, then that's when it gets opened up to others. Okay. All right.
Any other questions about this policy? And since it's an addition to our policies, we should take a vote on whether or not to approve it and add it to our current board policies. Is there a motion to? Is there a question?
Well,
Sorry. Go
sorry.
ahead. Yeah, no. There's.
I'm just trying to get, okay, so say I'm on the finance and revenue committee, and we have had a person resign to me, okay? So is it totally at our chair Cheryl's discretion whether we decide that we need more people or not?
Yes, yeah, and I'm sure she's, interested in the committee's opinion and so.
Yeah, I just kind of like to reflect that I think the committee should have a role in discussing, we've got enough of us, thank you, or no, we really need another person, and I just don't know that that should be just the committee chair.
Or a person with this expertise.
Whatever, so
Sure.
I'm sure that in reality, Cheryl, I'm not saying that you wouldn't do this, because we've had a brief discussion at our committee meeting that we would like to find another person, but then there was the problem that we didn't have a procedure to get one. So anyway, I guess I'm just looking for something that shows that we value the committee people who are on the committee to work with the chair to say, yes or no. And so, because it could be that one of the chairs just says, I got too big a committee, I don't want any more people. I don't want somebody coming in now, it's too hard. That's in that. Or we're having a discussion where that brings up and then the group decides and,
What if within that sentence, so committee members are nominated at the discretion of the committee chairs, with input from the committee and require approval of the board.
I'm back up at the more like just deciding whether we'll really.
So you want to, so if I'm hearing this correctly, what you are proposing is that the committees must vote on whether or not there
Committees
should
work
be.
with the committee chair
Well,
to
yeah, that's what I was saying.
decide whether a position needs to be filled or not, or, something like that.
So I would encourage all committee chairs to solicit input from their committees
Yes.
when deciding whether or not to add another member.
Yeah.
But I would leave it as remaining the committee chair's discretion as to whether to nominate someone or not after soliciting that.
So maybe you could just say after soliciting input from the committee.
Yeah,
Right, that's what I suggested.
Thank you, I'm sorry.
yes.
That's all.
Okay, so let me just, if I may, I'll read it back. So the sentence would be, committee members are nominated at the discretion of the committee chairs with input from committee members and require approval of the board.
That's down when, and I'm fine, and that's good, but that's down at that level of, we've decided we're gonna add somebody to the committee or not. I'm really more at the point of, I know some of the committees are large. And I don't know if I were the committee chair, then I would kind of say, do we really need another person? And also in this stage of the game, is it a little late and, we'll wait a lot of whatever. So, but I guess I would just like to know that the committee chair will have that discussion with.
Maybe like as committee members roll off, committee chair will, what you said.
Or something, I'm sorry, it's just, I should have.
I think it captures what you're saying, Mary Lou.
Okay,
That,
that's all.
that the chair will solicit input and
Yes.
then it's the chair's discretion.
Right.
Yeah, I think that, that captures what you're trying to say.
Thank you.
All right, so
I want to go on to.
we would keep it this with the additions, committee members. Are nominated at the discretion of the committee chairs. You could even put in parentheses with input from committee members and require approval of board or comment. Is that sufficient? Okay. Okay.
Great. Is there a motion to approve this as a policy? Second. Is there any further discussion? Great. Okay, let's do a roll call vote.
Colin Balanca,
Yes.
Chen Wei Chi,
Yes.
Amy Fellows.
Yes.
Michelle Glass,
Yes.
Bruce Goldberg is absent, Judy Richardson. Yes. Cheryl Ramirez is online and will text her vote in. Mary Lou.
Yes.
Great.
Thank you, Mimi, for that. And I just want to echo Mimi's comments on behalf of the whole board to thank our HMA consultants, Janine Smith and Anya Radar, for all of the work that they've done for this board. They have been really instrumental in helping us orient ourselves with our policies, with our committees, with how we think about spending. And we're really grateful for all the time and work that you've done for us. So thank you very much for that. And now, Mimi, would you like to introduce Morgan?
Oh, absolutely. Oh, sorry, we're still trying to work. So pleased to introduce, we have Morgan Shook from Echo Northwest, who's going to, who has been working very closely with the Finance and Revenue Committee, and delighted to have Morgan here to present the work of the Finance and Revenue Committee and Echo Northwest. So take it away, Morgan.
All right, can everybody hear me okay? I got a headset in here. Okay, great.
So I'm gonna make it
A little louder would be helpful.
Yeah, in the room.
A little louder? How is that? If I just speak a little louder?
That works.
Okay,
Yeah.
all right, let me go ahead and share. Okay. All right, is my deck sharing? Great.
Yes.
Yes.
Great. So I have a lot of slides here, but I think mostly I'm trying to tell a very sort of conceptual and linear story of the work of the Finance and Revenue Committee over the last several months. Echo has been engaged since April, and so we've been really enjoying our conversations and working with folks, Mary Lou and I think Richard are online. Maybe there are others who have done sort of tremendous work, and particularly people like Charlie Swanson, who have done also additional sort of heavy lifting on the analytics side that we've been able to help integrate and kind of use as a sort of foundational tool to center the conversation and I think start making decisions. And so I have some updated slides from the ones that were sent up that actually reflect a sort of vigorous and robust conversation of the Finance and Revenue Committee on Tuesday. So I don't think I need to sort of talk about the role of the committee, but I think it's worth just quickly centering on the fact that they have basically three big things they've been working on. One is to sort of understand sort of like, well, how much is this potential universal health plan likely to cost? What sources do we have in the system that are somewhat transferable or capturable? And then what might be the funding need? We need to sort of understand that gap. So how much money do we need to raise? And then what might be a strategy to actually fund that gap? And so I'm going to use today's conversation really to walk you through how the committee has kind of gone and tackled this and what their current state of discussion is, as well as some potential guidance they're looking from this board as they kind of move forward. So, the first, sure.
Okay, back on your first slide, the thing I think you didn't, that last dot point, no, one before that. Okay, the principles of equity, adequacy, and administrative feasibility. I think those are really key. And as we've struggled with this, the equity issue is a complex one, and you'll see that. But I think, and adequacy and administrative feasibility. So I think those three key principles, everything has been gone back and forth, and you've been very good helping us kind of say, okay, how does this either fit with what we believe about equity or not, or fit around getting adequacy? So I just wanted to.
Yeah, is that you, Mary Lou? I can kind of see on the edge of the camera.
Okay.
Yes.
Oh, okay, great. You know, Mary Lou's been fantastic in sort of in these conversations, and I think I will drive home that point. One of the documents that the Finance and Revenue Committee shared about a month and a half ago or so was an updated document about their principles for sound financial plan, and I think it's important that some of the calibration and the nature of the conversation today is really trying to find the right equilibrium across those pieces. Are we raising enough money? Are we doing it equitably? Is there really an administrative path to making this a set of practical solutions? So So let's start with the cost target. So, and I'll just say, preface this is the work that the committee has had to do to date. Actually, let me pause to say, if you have questions, Mimi in the room, if folks have them, please don't hesitate to interrupt. Folks that are online, just kind of give their hand raise. We'll be moving across a lot of material. So as you have questions, please don't hesitate to interrupt me. So on the first piece here is the committee has had to start with, well, how much is this plan likely to cost? Knowing that those details are really downstream of plan design and operations work that those committees, as supported by now Milliman, will be trying to derive. But in lieu of that, one of the things we want to make sure is just have a good sort of working target for that. And so the starting point for this is really understanding the work that's been done to date, both through various analyses of this, but particularly through the Joint Task Force and work that was done by Optimists. And they're here, right? We're really trying to derive two big ideas, right? What is the cost target? Right. And what is the funding gap? So this piece of work that was done through the spring was really trying to find some, we'll put them flags in the ground so that we could anchor a conversation around a funding gap and funding needs. And so the cost target is pretty straightforward in terms of the work. And I think the first thing I'd want to make sure to highlight is in the conversation, there are different levels of coverage, both in terms of plan benefit as well as populations covered. And the committee felt that we should be targeting sort of the PEB plus as our sort of understanding of the nature of this healthcare services that would be delivered under this universal health plan. And from there, we made some additional sort of accounting to understand that there may be some administrative efficiencies and cost saving that might make the plan a little less expensive, but also then we'd have to adjust for the fact that we might be adding covering more people, as well as the average cost of those individuals being added to the plan. And so from here, right, our work is to sort of then build off of the Optimist work and actually come with an assessment. And so based on the work done by Optimists and accelerating that forward, we thought a PEB plus plus universal coverage plus administrative savings. And if we started with kind of the current status quo spending, that's equivalent to about $55.6 billion in fiscal year 2026. Our work then to sort of make those adjustments for efficiencies, also expanded benefit scopes and broader coverage, then brought that down to an estimated cost of the plan of $54.6 billion. All right. Okay, so this table here is just for a little more clarity and to unpack this. So moving through the enrollment, the actual expenditures that were modeled in calendar year 19, and then inflating those using the healthcare expenditure inflation rate. And that's how we move from, if you're trying to follow the breadcrumbs from the work in the Joint Task Force and Optimists, we get from that 39 million that they cited to the 54 that the Finance and Revenue Committee is working off of. Okay, so once the committee has then established its cost target, we started moving into the funding gap analysis. And this is a conceptually straightforward exercise in that once we understand kind of the cost target, we're then examining transferable funding. So, and then the delta is really our funding target. And the quick summary of this really depended on basically two big areas of understanding, is particularly regarding whether or not federal waivers would be granted and the ability to take up Medicare, Medicaid as part of that. And so in the Optimus work, they had targeted the ability to basically cover all of those, to be able to get 100% of the waivers, as well as to find additional administrative savings. And their target was about 20 billion. Some additional work done by committee member Charlie Swanson thought that perhaps not all of those waivers would transfer, and so maybe the target might be 22 billion. But then we also wanted to kind of say, well, just for some understanding of this issue, if there was no waivers granted, what might the gap be? And we're closer to $40 billion in that case. So this handy table here puts forward two of the key sensitivities to understand on this question of transferable sources, and the federal Medicare, Medicaid numbers above on the sort of x-axis, and then you see the relative administrative efficiency capture, depending on sort of some of the work that HMA has done to kind of understand, like, well, could it be as high as 10% perhaps? Is there a kind of a worst case scenario? And we're trying to just map this out so people understand kind of the range, but we are working off of a target. And so you see between kind of the worst case and best case scenario, we're looking at a funding gap anywhere between 46 to 16 billion. The committee has been working in the sort of 20 to $22 billion range based on the work of Optimus as well as Charlie. And I'll just note in the calculator, because we're working backwards into fiscal year 2022 data, and we can talk a little bit about why we're doing that for the time being, that's roughly equivalent to the 18.4 billion in the Optimus scenario, just so you understand kind of these different numbers that are floating around. The committee has also been engaged in some understanding of the federal spending bill and the implications for Medicare and Medicaid. I think there's some certain uncertainty about what that might be, but in a kind of worst case scenario, maybe it pushes up the funding gap, but maybe a more optimistic reading might be somewhat less impactful. Okay.
Morgan?
Yep.
Can I ask a question about the scenario in which there are no waivers? So that presumes that, if we're not approved for any waivers for Medicare, Medicaid, then what you're presuming there is we're leaving all that federal money on the table. That Oregon's going to design this plan and fund it completely ourselves, and we're not going to have any federal funding for either Medicare or Medicaid. That's why that number is so high. Is that right?
Correct. Maybe not that the plan designed that way, but maybe other exogenous factors, but whatever the case would be, right, that somehow the ineligibility of those waivers would sort of show, and mostly it's just to show also the impact of all that spending, right? You're talking in the range of $25 billion that are at stake as part of that, basically almost half of the total plan cost. And so designing a plan that exploits the ability to get those waivers is so core to delivering on the funding needs.
Yeah. And then were any scenarios looking at, so for instance, if we got a Medicaid waiver, but not a Medicare waiver, and just sort of left Medicare out of the story, is that in there somewhere?
Yeah, we haven't gotten into that level of detail yet. And I think in the kind of worst case scenario is really just to help the conversation benchmark it, of sort of like, well, what does 20 billion mean? We're talking pretty big numbers relative to this sort of transferable waiver question. And so I think the committee has been paying attention to this, not just because of changes to the federal level, but as sort of plan design questions come up. I think the key piece here is that it's a key sensitivity to the transferableness and then what the funding gap is going to be.
And I think this, Mary Lou, I think the issue showing people, that right now, an awful lot of our medical care is paid for by the federal government. And I don't think the average person in the state really understands that or knows that or believes that. But it's there. And I think that's part of the problem with using Optimus stuff. There was a very different mindset a couple of years ago than there is now. And so this is a very difficult issue to go on. And when you see some of the even public comment, the woman who commented about Medicare, for example, that was with her understanding of what it might mean, but the progressivity of the taxes and et cetera. So it wouldn't mean that everybody's going to have, and somewhere it keeps floating out here, 15% increase. I mean, I don't know where that has taken hold, but I keep hearing it out in the community, and I'm going, wait, that hasn't been decided yet, and it won't be the same for everybody. And so that'll be part of our thing of once we do kind of land on this, how to lay it out so people can understand a very complex issue. Morgan's doing a great job. Thank you.
All right, I'll keep moving. Here we go. So I would say then, right, the first two key pieces of the work, I'll call it in the review mirror, but at least some sort of settled, so that we can begin the question around, well, how do we sort of attack this gap? So if we're working off of fiscal year 2026, 54 billion and some change, and we're trying to target somewhere in the range of 20 to 22 billion in terms of funding gap, how do we start thinking about a revenue strategy? And the committee really done kind of a two-step process here. And the first process was really to say, I think putting their sort of adequacy hat on here, given the tax tools and tax bases available to the state, either current in use or within some administrative sort of window to actually execute on, what are really kind of our core options, right? And then to say, well, there are additional other taxes that we might want to consider from a sort of nexus perspective, because the beneficiaries of the service may then need a cost to exact, as well as other sort of policy tools that are operating on a little more targeted basis, and we'll get into these pieces. And then so once we had kind of this sort of broader sort of adequacy question, but then supplemented on sort of these administrative equity principles that the committee has been centered on, could we start assembling candidate, we'll call them scenarios, working scenarios that are likely to be advanced as potential proposals. And so let me talk a little bit about that first stage, and then the remainder of the piece we'll talk about the second stage of the committee's work, particularly over the last month. We won't spend too much time on this, but this is kind of an example of a little of the work that we're trying to say, well, from an adequacy perspective, like if we're trying to target $20 billion and we're working off of the tools that are currently in place, how can we, as a sort of measure of sort of existing tax base and tax rate and how much is being produced out of those tools, this is sort of a beginning place to understand, like, well, what's actually going to do the heavy lifting here if we were able to move forward. And so you can kind of see the sort of differentiation between what we call kind of the major food groups versus some of the side dishes with respect to the current funding that's in place. And I said this matrix here, I think, is really more illustrative of the question of the sort of nature of the conversation that Finance and Revenue Committee members have undergone as they sort of tried to sort of sort through kind of those major food groups, their basis, as well as some of the sort of downstream equity and administrative questions that they're trying to articulate. And so out of this conversation, the last month and a half, I guess the last 2 to 3 meetings, the committee has basically come to an understanding that because of the scale, right, there's not one tool here. There's no silver bullet that's going to be able to bear this. And so the tools have to work in some combination of each other. And then they could supplement that with kind of these side dishes. One of the other key pieces that's really part of this is, I would say, trying to balance 2 key principles of what they call kind of economic efficiency, as well as economic equity. And so on the efficiency side, the nature of the conversation has really been, how can we raise significant revenue here and try not to distort the decision making of firms and households because of the tax incident and burden that's being placed, right? So they think the committee members have been very attuned to try not to create a package here, in particularly given the size of the need, that is going to be wholly disruptive to those choices as much as possible. So I think that's one side of it. The other part of it here is they're trying to pay attention to the sort of equity provision, particularly sort of what they call the vertical equity. So this is really ability to pay idea where try relative to the amount that is being funded, how can the tax code be used to raise revenue in a way that does not marginally impact those households whose incomes are so low that you're placing a significant burden on their household budgets. So what then are the conversation of the core funding tools? And I think as you've seen in the slide before, the personal income tax in Oregon is the largest funding tool for currently, and is one here, given the nature of the service being provided, is targeted for that piece. Businesses currently pay the majority, well, not majority, but quite a bit of the current healthcare plans of their employees. And the idea here is to use an employer payroll tax to basically mimic those payments. So as those premiums go away, businesses would then be subject to a payroll tax. The committee has also looked at other business taxes like the current corporate income tax and the corporate activity tax as also areas where the business community potentially could contribute. Then another key idea here is that individuals currently are paying premiums, whether as part of their current employer-sponsored plan or through their state marketplace plans, and that there should be potentially some type of cost sharing that would mimic their current way they pay these healthcare premiums. The committee then has also looked at two taxes that currently aren't used in Oregon right now. The first is a value add tax. VAT is very common in across globally, but is not used in the United States. And the reason people like VATs is because they tend to be efficient and don't sort of tax. They tax the final product and final demand as opposed to sort of the inputs, and so it becomes a little more efficient and just doesn't distort economic activity as much. But the committee decided to leave that tax off just because the fact that it would touch on too many national issues as opposed to a state issue. The committee has been diving into a sales tax. As everyone knows, Oregon does not have a sales tax. Previous efforts to create one through initiative have failed, and so the committee is very much aware of the sort of past challenges with this tool, but you'll see here is still part of the conversation. So the side dishes here are kind of, we'll call them supplementary or purpose-driven tools. And the first one is lodging or other tourism taxes. And here the committee feels that there is a nexus between visitors, either through providing emergency care or care for those who are uncovered, perhaps, or undercovered, as well as sort of to potentially administer claims for service that has been provided. And the best tax tool that they can see today is through some expansion of the lodging tax. And then the sin taxes, if you look at the current set of cigarette, beer, and wine taxes, as well as marijuana taxes, they are fairly small revenue generators, but the committee believes that they're given the healthcare costs of these activities, some sort of Pagovian taxation to both raise a little revenue, but also hopefully to discourage use, should be part of the package. So once we've had that sort of conversation of how to put it together, the last two meetings, the committee has actually done some work to try to develop, we'll call them scenarios or early stage proposals to sort of help test these ideas around adequacy, equity, administrative feasibility, as well as sort of how different burdens between individuals and households, and then some of the progressivity issues around equity might shake out. So as a sort of starting point, and this is we're getting into slides that were used at this Tuesday's Finance and Revenue Committee. Scenario one was really to say, well, let's just look at our core food groups here of the corporate income tax, corporate activity tax, and employer payroll tax, personal income tax, and some personal premium that would be administered through the personal income tax as the way to operationalize that payment. And so the rationale here was really to try to anchor first on the businesses paying some share of corporate income tax, corporate activity tax, and there should be payroll tax. I forgot one edit there. And then make that neutral for businesses, and then raise the additional revenue through the personal income tax and personal premium. And the reason for this sort of idea is really just to test some of these ideas around adequacy, equity, and efficiency. None of the sales taxes or any of the other side groups were modeled in this little scenario, right? Again, the intended effects to keep the corporate share of total contributions the same, align with sort of equity goals to protect lower income households, avoid some of these sort of potential taxation issues on wages, and then to place some higher level caps on total contributions to address excessive burden. And then just to start with a simplified understanding of this before we started layering on some of these additional taxes. And so what you see on the tape, okay, sorry, there's a question.
It's Mimi. I am wondering if you, because I think this has come up a couple of times, if you could talk about kind of specifically what is meant by avoiding double taxation of wages, because I think that is a little bit confusing. So maybe
yes, yeah, I was gonna get into this on the next slide, but this is a great question. So if you look at that table here, what you see is like, well, why aren't we raising any revenue on the payroll tax? And the reason for this here is a key feature and principle of the committee is sort of this dual nature of sort of efficiency and equity. And the starting point of that is really to say we want the businesses to continue to contribute at levels they're currently contributing for their employer health plans. And the main vehicle for this, even though we're going to maybe perhaps ratchet up the commercial activity tax or the corporate income tax, the main basis of this is the payroll tax. And so if we were to replace all that current spending, we're roughly at about $7.1 or $7.2 billion are being paid by businesses on a payroll tax. Now, and so the other piece of this was really to say, well, we want that to be as progressive as possible. And so I think, and this is maybe there is room for reasonable people to disagree on this question of taxation and efficiency. And I think Mary Lou has been one of those folks. But the main idea here is to say that employee compensation is a sum of their wages as well as their benefits. And right now, healthcare expenditures on their plan are a type of benefit that companies balance against their total sort of employee compensation, not just wages. And so if we want to sort of keep that neutral and to change the premium payments with an employer payroll tax, one way to sort of make it much more, so by doing that, you make it efficient. So the business is still technically paying the tax, but the ultimate funding then, because if you're offering a credit against that, you are able to make that deployment of that tax much more equitable by distributing it across the income tax. And so what happens here is employees then can claim the payroll tax, just their state portion, not the federal pieces. We're talking strictly about the state income tax. Would be able, and I think there's still some questions we're looking at for on these questions to the Department of Justice to make sure that we understand some of the tax pieces and from the administrative feasibility side of it. But then the idea is really to say, let's let employees or individuals claim that payment as a credit against their income tax. And so think of it as basically if an employer paid $10,000 in expense and payroll taxes per employee, that employee then could claim a $10,000 tax credit. What that does, right, is a tax expenditure, right? So you raise the revenue through the payroll tax, but then you gave it right back to individuals, and you still need to raise additional revenue. And so in order to do that, you have to sort of redistribute that across the income tax spectrum. And so here's where it allows you to make the income tax more or less progressive, depending on how you want to structure that. But that's the basic idea, is to sort of, even though businesses are the first incident paying the payroll tax, you're basically giving all that money back as a credit. But then you have to raise that same $7.2 billion through an additional income tax that you can be much more progressive on. So in this case, right, what we've done is to say, okay, we're going to raise that 7.2 billion through the payroll tax. We're going to give it all back in the personal income tax, but that means we need to have an income tax rate of 6% that we can then distribute progressively. We'll talk about how that works with some combination of these caps that moderate total tax paid. So if we look at this, right, even though we're raising 7.2, we give it back, but then we need to raise money both in the personal income tax, a per person premium, and then you see the additional taxes. There is some additional tax that's not credited against here, but that just gives you some sense of how this is working. So this is just another chart to help make hopefully clearer sort of the net change. So we're not looking at total contributions here, we're looking at the net change. So the starting point for this scenario was to say, let's keep private employers paying the same amount, this sort of economic efficiency idea. And so what you see there is, right, we haven't really changed the total payments here. And then what's happening is, right, is the total revenue being raised relative to the status quo is being moved to individuals through higher income taxes and premiums. Go ahead, Michelle.
Thank you for this. I just had a question about this graph. It looks like it's not taking into consideration, and maybe because there's so much variance, do we have any estimates of what individuals are paying on average in premiums right now?
Yeah,
This graph looks very alarming. I sit on the communications and community engagement committee, and I'm just imagining a response
yes,
from a member of the public. So I
we have, yeah, no, this is a question we are dealing with. I think we're kind of building the plane as we're flying it here, and so I think trying to make sure we have a lot more charts that kind of communicate some of these complex ideas is something we're continue to work on. I would say the best thing we have right now is this relative change, because so if we're moving the burden mostly to individuals, right, on a net basis to sort of cover kind of what they're paying today and what they're paying in the future, this chart here shows the combination of marginally more income tax and personal premiums paid by adjusted gross income band. And so, and we're doing this through a couple different measures. The first one is, where does the premium and income tax phase in, right? So we're setting kind of a threshold, individuals under some level, and currently we're in this little chart, it's just showing 140,000, oh, sorry, 140% of the federal poverty level, which I believe is around for a family, a household of two, around 40,000 adjusted gross income, just as a reference point. And so what you see there, right, those individuals below that threshold are not paying really any more than they currently are today. in this situation. And what through sort of these sort of equity measures of phasing in these sort of what we're calling soft caps, right? They're trying to then marginally decrease the amount of taxation as we get into higher income bands. You see the effect of that. So kind of starting in that sort of 50 to 60 AGI band, you see the progressive revenue raising output of some of these policies move forward. So, and this is just showing total amount paid. It's not in one of the charts we have here that probably would be helpful too, is also the relative percentage of payment to income. And so that if we showed that chart, you would see basically we're trying to keep that as flat as possible. So individuals aren't being taxed, even though they're paying more, it's relatively flat as a percentage of income. And so that's how right now the committee is sort of is expressing this sort of equity principle in their fundraising question or discussions. Is that helpful, Michelle?
It's definitely helpful.
Yeah.
And like I said, maybe it's not possible. I think where you showed, you were able to calculate what businesses are currently paying, and then show that it was, relatively, like there was some context there, and that individual amount, there wasn't that context of, what we're paying on average for premiums now, for cost sharing now. And I think that would be a really helpful component as these public documents are disseminated or viewed, just so that there's not any misunderstandings early on that could be harmful.
Yeah, I think as we revise these charts, we'll include both as best we can, kind of current payments, new payment, and because what we're showing in both these charts is just net differences, and so we can add that. Okay.
And I wonder if I can try to say back to you what I think you just said, so that I'm clear on it. But I think what you're talking about right now with this double tax is kind of one of the foundational things of what a universal health plan is trying to do, which is decouple health insurance from your employer. And if I think I heard you right, that like right now, if you took a random company and you assumed that they were paying for healthcare for all their employees, and every employee got $10,000 worth of healthcare premiums paid on their behalf by their employers, but they're paying $10,000 for everybody, regardless of those employees' varying incomes, right? And so now what we're trying to do is say, okay, that company is still going to pay $10,000 on behalf of every employee they have, but now they're just going to give it straight to the universal health plan. And because it was previously a benefit as an employee, we're gonna let every employee take a $10,000 credit so that they still realize that benefit, right? And now, though, they're going to have a new income tax, but the income tax will be progressive, whereas the $10,000 wasn't progressive. So now you are going to pay more individually, but it'll be progressive and will account for your income. So it'll be a more equitable way of paying for your health care, and it decouples it from your employer. So it just separates your payment of your health care from your employer. But that's why it looks like the burden, quote unquote, burden of paying for healthcare is now on individuals and families, but that's because we're trying to get to this decoupling thing. Did I capture that right?
Yeah, I think that's fair, because the universal health plan will still get a check for $7.2 billion from the payroll tax, right? That's a deposit. But and then I think what you're saying is correct. Is like, well, we want to sort of create a separate way to fund this for individuals, right? And that is through some combination of having a personal premium plus a income tax that is designed to be as progressive as the committee deems reasonable.
Right. Okay. Amy's got her hand up.
So on Helen's point, and kind of back to what Michelle said, like the reality now is the employer might pay that $10,000, but employees are also paying an additional $6,000 to $10,000 a year in premiums on top of the employer contribution. There's very few people whose employers are covering all of their premiums in this day and age. So I think showing that now you're paying $6,000 a year in your premiums in addition to what your employer is doing, And with our plan, you know, it will be this progressive thing. And so, you know, maybe the top 500,000 plus people, you know, I don't know, they're still paying something closer to that, and the people, you know, and then it's like prorated down. But that one slide, I have concerns also that we did not do that.
The one about
The individual
versus-
calculations showing that, and it looks like if people are just looking at our stuff and not diving into it,
Right,
that individuals are going to be paying tons more than
right.
businesses aren't. So I think whatever we can do to update that as soon as
Yeah,
possible.
you know, if I had to say, I had to say it like
These are
as
already
as a class, individuals are paying more, but as an individual, you may be paying more or less depending on your income.
Yes.
And so what this chart is showing is the current thinking of the committee to say for individuals who uh, um, um, at the lower income bands, the intent is to have them pay almost nothing for the most part. Yes. And to shift that sort of average individual contribution to higher income households.
Morgan, this is, you know, my old saw that I had said at the committee meetings about this way that the payroll tax and then kind of crediting back to everybody, you know, kind of at a flat rate kind of thing, presupposes the concept that an employer has X amount of money to spend, and that they're spending it now on people's paycheck and on benefits. And that if they don't have to pay for those benefits anymore, but they're paying a payroll tax, the idea of crediting back all of that money to the individuals presupposes that the employer will increase wages from what they're currently paying. I still struggle as a committee member with the idea. I think when people say employer payroll tax, they kind of want the employers to be really, you know, paying that. And I'm getting myself all twisted up, as you can see.
Yeah.
And this is going to be part of the problem in trying
So
to explain it to your average person on why we give all that money back, but then we charge you more on your income. And I think Helen said it best when she kind of said that we're trying to make it more progressive, but to do that, it's complicated to explain. Sorry, Michelle.
no, you know, Mary Lou, I think just as a good point of emphasis is employers are still, the intent is that for have employers to still pay, right? They are paying, they are writing that check on the employer payroll tax.
Right.
What the efficiency equity piece here is to say, we don't want that to come at the expense of compensation, perhaps. And so think of it as basically, if you were trying to raise more revenue, right? And this is kind of like I think the point of controversy and or sort of where people reasonably can disagree, given the evidence in here, is like, well, if we made it more expensive for business, like let's say we doubled the payroll tax relative to current contributions from employers on their health plans. Basically, total compensation then is like, well, what might the effect be? Were you paying people less? Would be potentially slow hiring, right? Would we hire fewer people, right? So I think the question on the efficiency side is really to say, can we not distort those questions? And I see Linda, who submitted some comments, and I think Helen read her pieces, raises some good points here. There's some real questions on sort of to the extent that interaction between federal and state pieces are important, and then to the extent that they're, whether or not you are sort of taxing that income twice. And I think what Mary Lou has raised is sort of this sort of area where I think there's still more conversation that the committee wants to have in this space, because I think it's not clear, and we'll be spending more time as a committee in that space.
Thank you.
So Morgan, just one more point of clarification then on that. So if in a hypothetical situation, somebody's current wage is 80 and they're getting 80,000 and they're getting $10,000 worth of healthcare from their employer, then the employer is telling the employee, you have like $90,000 in wages and benefits, right?
Yep,
And
yep.
so under this new scenario, their wage would stay 80, but they would get a $10,000 tax credit. Or
Yes.
in lieu of the benefit they're getting from their employer, their wages would go to 90 and then there'd be a payroll tax and a credit.
It would, their wages would stay the same. So the thing of it is basically, the idea is not to raise total compensation more than 90, right? So like say you plus, you in a payroll tax where the current contribution is 20,000, but now the payroll tax is 30,000, right? Employee compensation has gone to 100, right? Or sorry, 110 in your scenario. And so the idea is really not to make it 110. The credit piece, right, is a way to say everybody gets the credit, and then we can design the total funding of the plan more progressively, right? As opposed to sort of more horizontally. Think about it. If we just said like, oh, let's raise it to the pit and then not give people that credit, you're limited more in terms of how progressive you can deal with some of these equity questions.
I see, yeah, I see. Okay. I know to say, Linda, we see your hand, but during board meetings, we don't accept discussion from public members. So we always really appreciate your comments and your input. And so please continue to provide those to the Finance and Revenue Committee.
Yeah, and I'll say, Linda, I had a chance to read your comment, and we'll be trying. I can reach back out with some feedback too.
Yeah, great. Go ahead, Morgan.
All right. So the next, so that was really just a question of adequacy. It was basically, hey, we have I would say the shorthand is we have some idea what our major food groups are. We have some principles to start talking about what rates would be used, right? And these aren't proposals. These are just ideas to stimulate discussion. And then the next part of that is to run a scenario here where what happens, right, if we then introduce a new major food group, the sales tax, as well as some of these additional targeted nexus taxes like the lodging tax and some of this, quote unquote, sin taxes. The big thing that changes here, right, is if we're introducing the sales tax, and what you'll see here is that the sales tax, right, is at 5%. Just that's not a proposal. That is just a number pulled out of thin air, right? The state and the tax in Idaho is a little less. The sale tax in Washington is a little more, and so we're just picking something to give us something to work on here. And so, but at 5%, given some rough understanding what might count as a taxable retail sale in Oregon, we might be raising revenue in the sort of $4.2 billion range. What we've done here then is to kind of still keep that target at 18 million. We've reduced the personal income tax a bit so that it is not as reliant, but we've kept kind of the premium similar. And what happens here, right, is, and this is probably a bit misleading, private employers are paying a little more through the corporate income tax and corporate activity tax relative to their payroll tax, but we're also getting some additional funding from the beer and wine tax, which technically is paid by individuals, paid by businesses, but typically passed on to individuals. And so, for the time being, we're just lumping them here just so you know that. We don't see a big change in the rough distribution of in payments to individuals. It goes down a little bit, but this is really reflective of the sales tax, right? And so they think of it as we're subbing out one individual tax on the income tax side here, and then augmenting it with a new tax paid by individuals and some business pieces, right? Businesses do pay for goods and services that would be subject to the sales tax, and so you do see that sort of balance out. But given the scenario we're running with here for discussion, we don't see a whole lot of change because of that burden shift. And so what you see here then is when we've tried to sort of model those sort of changes, you see a very similar sort of picture of taxes paid between the income tax and the premium tax. What we don't have here is the sales tax because we just don't have good data to sort of model the payments. But you would expect more payments of the sales tax because it's unavoidable for goods and services, particularly at the lower income. This is why sales taxes are generally viewed as a more regressive type of tax source. So, yep.
Or here, oh, okay, I think just explaining to people, in the insurance business, we use the word premium as, what you pay, your individual payment for your insurance coverage. This is not using that word in the same way. This is saying that people who are of a certain income level will pay more income tax.
Yeah.
Kind of a premium above kind of the regular.
It's both.
But
Yeah.
there's not going to be a premium paid.
That's in the model.
Yeah. So what is being modeled here, what you're seeing here, is the net change of both income tax and the premium, but both are being modeled with phase-ins that redistribute. Think of it as on average, we're targeting a $5,000 premium in this case, but because we can phase it in by income, right, and we're trying to be attentive to the net change of individuals in this space, what we see is basically we're keeping them no net change to their payments. So think of it as basically the best way to operationalize a per person individual sort of premium payment would actually be through the collection of the income tax is the thinking. So you would basically pay your premium and your income tax at the same time, but because of the way we can adjust by income at that time when people do filing, you can make it more or less progressive depending on policy. Like when does it phase in? What are the changes in the marginal rates to influence the nature of this curve?
Just piggyback on Mary's comment. We can label it as premium, but strictly speaking, in public finance, anything mandated by government is tax. Whether it's a fine or whatever name you call it, it's a tax. But we can label that, but we need to recognize it's tax.
Yeah, I think, is that Chun Wei? I think that's a great distinction, right? Is that even though we're trying to design it perhaps as a fee, but conceptually, we operationalize it and it's collected as a tax.
And so in this graph where, you have that line at 5,000, there's certain income levels that would be at the $5,000 level. That's the total combined of their income tax and this premium. That's the total they would pay. It's not.
This is net change. And so it's not, so I think this is Michelle's question. It'd be nice to know what they're paying now and what they're paying in the future. What we're showing here is just the difference, right? So as if we were to create this sort of funding scenario, who's paying more or less relative to the status quo?
Individuals in these income brackets, this is how much more they'll pay than they're currently paying.
Correct.
Yeah. And they're currently paying through our current model where they're
Some understanding of what they're paying on premiums per individual, adjusted gross income and income tax.
So average income in Oregon is around $80,000. And so in that bracket, the average person would pay about $2,000 more than they currently pay for healthcare.
Correct.
That's a lot.
And on the sales tax piece, was that just an exploration? Because I think having been a lifelong Oregonian,
It's up for us to discuss. You should put it out there as an option.
okay, I just think we need to understand the reality of that and the reality of legislators supporting this if there's a sales tax.
Yeah. So we'll have a little discussion. Let's let Oregon do his presentation, and then we can kind of take it from there.
Yep, and that'll be a good prelude here to some coming slides on the sales tax question. So I'm going to run through these quickly just to kind of give you flavor of the topical areas of discussion. The first one here is from a payroll tax perspective, and this is kind of the efficiency principle, is which kinds of firms would be subject to the payroll tax. There currently are exemptions and thresholds. So basically, how big would you need to be? And so the committee has been thinking about like, well, how do we want to phase in the payroll tax by the size of the firm measured by the size of their payroll? And so I think the general idea here is if you set it lower, you're pulling in more small businesses at a higher rate, but perhaps you could set the rate higher so that, progressively smaller firms are paying a little less relative to bigger firms. And so that's been one big point of conversation that the committee has been. The other piece that we have talked about, and as Mary Lou has alluded, is how much should the I didn't catch all my edits. The payroll tax count against or be credited against one's personal income tax. And so, the kind of pros and cons are really about sort of, should you have this sort of double taxation and how do we deal with distributional effects? And I think we know that individuals have different levels of thinking on that question. The other big piece is this payment cap. So basically, the term that the committee has been using is soft cap. But think of it as basically you could have a soft cap or a hard cap. A hard cap would be to say once an individual pays so much in tax for the universal health plan, they'll pay no more, right? So say you said, okay, once you pay $30,000 in total tax per individual or per AGI, like you shouldn't be subject to any more tax. That would be an example of a hard cap. What the committee has been talking about is a soft cap, where at a certain threshold, the tax starts to fade down a little bit. So the marginal rate that you're being taxed kind of goes down. Not that it goes to zero, but that as you kind of, hit a certain point, whether that be 20, 30, 50, right? That the marginal rate kind of goes down a little bit more. So you're not taxing that higher income as much. And so this is the other big question on the personal income tax side and the premium side that the committee is talking about. The last is really about what we're calling the personal premium, right? So, like a tax contribution. And the question here is really about how much should you raise? What should be the per premium rate? And then how should you phase it in per the income distribution? You could set that a little lower, right, where people are paying a little more, or you could set it a little higher. And so these four issues are over the last two meetings is where the committee has had much of their conversation and actually have sort of made some, I'll call it progress in the sense that there's some consensus thinking around these issues that they would like you to know and take feedback on. The first one here is they believe that likely the core proposal, and so we'll call it our working scenario, will include the corporate income tax to some level, the corporate activity tax to some level, an employer payroll tax, this personal income tax, as well as the personal premium, right, that would be implemented through the personal income tax. That they believe would be kind of be the main food groups as part of their core proposal. They are excluding the sales tax, I think, for some of the reasons that I think I've heard thus far and that people are pretty aware of, but they would like to retain it as a study option and a counterfactual option that the Universal Health Plan Governing Board you guys can continue to consider. And so think of it as basically kind of we'll have a preferred alternative or proposal, but there may be sort of a counterfactual or optional alternative that they would like. And I think the main piece of that is because of the significant size of revenue that could be raised through a sales tax. There's some additional questions that we're working on, but mostly understanding like administratively, what would it take the state to do this? How much of the sales tax proceeds would have to be implemented or consumed to administer the tax. With respect to the other additional supplemental taxes, the committee believes that the lodging tax should be used as a nexus point for care for visitors and to any administrative claims and costs to cover those costs of administrative claims for visitors who are using the health system in Oregon while they're here visiting. The committee is also supportive of incrementally increasing the sin taxes, particularly for cigarettes, marijuana, beer, and wine, at a minimum, but also would like to explore other taxes used. And so we're looking at like sugary beverages, perhaps vaping. But here it's really the nexus to the public health costs of some of these activities and making sure that one, that the tax acts Pagovian, so discourages use, but at the same time raising revenue for the costs of some of those activities. So we're doing some work to look at sort of what other states are doing, just so we understand relative rates and administration, as well as what taxes are in place. With those 4 big questions we talked about on sort of the equity side of thing, on the employer payroll tax, the committee does feel like there should be some phase-in, so threshold where marginally smaller businesses are taxed increment marginally less than larger businesses. And so we are basically looking at roughly a $300,000 kind of threshold. I would call that kind of a loose consensus right now, because we're trying to solve for it. But the basic idea is to understand how much revenue we're trying to replace from the employer payroll tax, and then to figure out the threshold and what the marginal rate needs to be in order to raise that sort of similar amount of money that they're currently spending on employee health plans. With the personal income tax, I think there is consensus that the employer paid payroll tax should be PIK credible. And I think a lot of this is because of the desire to make the taxation and revenue raising more progressive, and that there is support for a soft cap at some level of total tax paid. I don't think there is any consensus for a hard cap at the current time. There is also a consensus around having some level of personal premium. And right now, roughly, we are targeting a phase in at about 200% of federal poverty level. But the final design will really be, think of it as, once we understand how much revenue can be raised at relative marginal rates in the personal income tax, the personal premium is basically used to kind of solve out the remainder. So I think that brings me current to the conversation of finance and revenue as of last Tuesday. There are some questions here, but I'll hold those for a sec. Since Mary Lou is in attendance, Mary Lou, anything else you want to add to the summary of the conversation on Tuesday, based on your perspective?
Oh, you're not going to go through this slide first, or?
No, I can wait. I don't know if you have any other kind of final
No,
remarks on kind of where things landed on Tuesday.
Yeah, no, the issue about the employer payroll tax issue, I think when I had a little trouble with soft cap and hard cap, but basically, like Social Security is a hard cap. Once you reach a certain amount of income, you don't pay any more into Social Security. That's it. The soft cap is you would get there, but then you pay a smaller percentage than you've been paying down below. And so that's kind of the difference between hard and soft cap. In my mind, if I got that right, Morgan?
You got it.
Okay. Let's see. The sales tax thing, we said, okay, let's look at what it would look like and how much would it bring in and that kind of thing. But the committee is not in favor of sales tax. And I doubt could we come back and say, let's have that be part of the plan. Okay.
So how much money are you going to spend on exploring?
Well, I don't know, it's in, how much money are we
I
spending?
mean, we
exploring
don't know
it?
that now, but just the kind of idea that.
Yeah,
I think that's a board level decision. So actually, I think Morgan's gonna.
so that didn't really come up. Okay, I think you've done a good job, Morgan, of trying to explain, a lot of discussion, a lot of things that are difficult to kind of comprehend and understand, and there's still a lot of ways to go, but we're just kind of moving along as best we can. And I think that having Morgan and Echo Northwest here to help us with this, we've made some giant leaps in the last couple of months. Thank you.
Thanks, Mary Lou. And so I would say I'm gonna leave it here with kind of 3 questions that board members, committee members asked for the board. One, I think, is just some feedback on the current trajectory, what you've seen today in terms of the cost setting, the funding target, and the revenue strategy discussion that the committee has had to date. And so basically, are we on the right track here for a single payer model consistent with the joint task force recommendations of covering everyone in Oregon? Or to what extent should we be also shifting, expanding the focus to include a revenue strategy that does not, have that level of benefits and or that level of coverage? And so though perhaps for those persons eligible for Medicare, perhaps. Relatedly, right, the question is, in either one of those system scope pieces, are we right in thinking about the current or sort of level of benefits of PEB Plus, or are we looking at, should we be thinking about other cost targets? And maybe this will come out of plan design and work with Milliman that might have other more limited benefit options that would change sort of the revenue strategy a bit. So I don't know, Mimi, anything else you want to add to those set of questions? But I think kind of pretty expansive everything you've seen today, as well as sort of where things going with plan design and coverage.
Yeah, I think that's exactly right. And I think that the committee was, as Mary Lou was pointing out, was just, kind of obviously not expecting, because they didn't put forth a proposal, not expecting some sort of hard answer, but just saying that it would be beneficial to either, should the scope be expanded a little bit, or in some areas and maybe narrowed in others. So I think that's really what they're hoping for the discussion from the board.
And I think that the issue about Medicare has, especially John Santa, has really brought up and continues to have us, and we haven't really delved into it at the level where I think I could explain, although I think the public, and especially people in my age, I am on Medicare. So people who are on Medicare that I talk to are kind of nervous about, what does this mean? Will I still be paying my federal premium out of my Social Security check? Will it be on top? What's up? And I think that really we're going to have to, and John encourages to really have, and I don't know whether Plan Benefit and Design is looking at this issue about Medicare as a real group, even different than Medicaid, because Medicaid, people are not paying any premiums, they really aren't paying, and I think we take care of the progressivity, et cetera, but Medicare is kind of another fish to fry there.
So the legislation requires us to come up with a plan that would cover everyone under a single payer type strategy. So this board is obligated to put a plan together that does look at what it would take to cover everybody and what the revenue strategy would look like for that. But I've always been of the thinking, and I think others on the board agree, correct me if I'm wrong, is that in addition to putting forth that proposal, we would offer the legislature several different options of other things that we've considered. And as we talked about earlier, we are highly dependent on getting federal waivers. And in the instance where we can't get federal waivers, I think it behooves us to kind of put forth a plan that say, here's what it would look like, for instance, if we didn't get a waiver for Medicare, or if we wanted to carve that out and preserve Medicare as it is and cover everybody else who's not eligible for Medicare. I think that would be a reasonable alternative to the main proposal, and something that we should definitely explore. And then we are talking about changes to the benefit design and ways to look at the benefits that are offered to make the revenue strategy a little bit more feasible.
I think that the only thing that came up very much at the very end of our last meeting, and if you listen to the tape, Charlie Swanson, who really digs into a lot of detail on a lot of this stuff. Started looking at Medicaid, and from his quick look and you know, kind of bringing it up, there may be a way actually to get as much, if not potentially more money from Medicaid if we did not have a waiver. And I can't explain how that, but there are in Medicaid law kinds of ways, depending on what the state is putting in, that you get an equal amount from the feds. And if we're putting in a bunch more money here, that it may be able to draw down.
For the provider taxes.
Yeah, so.
Which are changing.
Yeah.
Well,
I
it
think
wasn't
that-
provider tax.
But does that include disability and in-home community supports? Otherwise, it's leading to institutionalization.
Yes, no, I don't know. Those are the questions. I'm just saying that if you watch the proceedings of our last meeting, that kind of came up at the very end. And so some of these suppositions, I think we need to go down the path of looking at what do they mean and what is the process. But it was just kind of like a, what?
Right, and I don't think that's been necessarily validated
Yeah.
widely, so it was a thought,
Right.
so
And I
just.
just, but people, I thought, you know, if they're watching, I don't know how closely everybody's watching all these meetings. And somebody will say, well, why didn't that ever happen? Well, it's because it's really just a very.
Did anyone else have thoughts on the questions posed by the committee to the board?
I think Michelle has her hand up.
Oh, Michelle, go ahead.
Thank you,
Okay.
Chair. And thank you, Morgan, for this presentation. This has been really, really great. I guess one question I have, since this is an unknown, that whether or not we will get a waiver for Medicare, are we, because of capacity and time and resource constraints, do we have to choose one or the other, or could we move forward with two contingencies with planning? Is there capacity for that?
Absolutely.
Because that would
Probably
make
more.
sense to me.
Yeah, go ahead, Judy.
I have two questions. Thank you for this presentation. I thought it was very clear. My first question, in 2023, the state of Oregon gleaned 900 million from lottery revenues. And I know that's earmarked now like 50% to education, 25% to economic development, and the rest like natural resources. But did the committee consider trying to leverage for a portion of that pie of lottery revenue? That's my first question.
I don't think so. While I've been there, I've never, Joey, you've been on the committee longer. Has lottery funds ever come up?
No,
It's not the whole tamale, but it would be a little bit. My next question is, and forgive me, Morgan, if this is outside the scope of this analysis at this point, but looking forward and looking at this model of revenue streams, when we start to think about cost growth trajectories, are there any assumptions about the bumpers and barriers of how that cost growth for healthcare expenses needs to be reined in, mitigated, or are there certain components of the model that dry up faster than others if costs continue to increase at a rate that's unsustainable?
Yeah, as far as at least with number one, I mean, and I'll echo Mary Lou, I don't think we've had any conversation, at least I haven't had in the last several months on lottery, so we can raise that as a topic. On the second piece, this is something that we've raised and in like some very early conversations with Milliman around cost containment and what stabilizers are available. To the extent that that is incorporated in our thinking right now, it's really through the revenue side, in the sense of like, this is because we are talking about fixed rates and revenue that's going to be depending on sort of what happens with the economy. In any given year, these tools are raising revenue and act as their own sort of like cost containment. So basically, cost containment has to happen on sort of how does one handle payments and expenditures of the plan relative to the dollar being raised. And so that's something we can start talking about on the revenue side, whether there should be stabilizers in there. The only other place, right, we've been dealing with that is really on the reserve question. To what extent should we be targeting higher or lower reserves to basically make up for shortfalls in expected revenue, not necessarily sort of increases in expenses. But I think that will be part of the conversation going forward, and we'll have to sort of map that out.
I think that's a great question, because if we're basing a lot of our revenue on income taxes and rate of income taxes, the cost of healthcare services are rising a lot faster than people's wages. So we're gonna quickly get underwater with that. So, yeah, that's a really good thing to bring up. And, but we are already in this very early stage with Milliman already talking about cost containment strategies. So I feel like that's probably gonna be really useful to work with them on that, yeah.
Couple
Go ahead,
of
Amy.
questions, comments. Okay, so one is, as someone who's been kind of small business to 99 contractor for 15 years, and knowing that when people are no longer tethered to employment for the sake of healthcare, right, that group may grow, there may be more kind of entrepreneurial and, you know, people trying to
Leave their jobs and do something else.
yeah, or have a sense of balance in their lives, all those things. So I don't know how we would estimate that. But I think we just need to be aware that a chunk of people that will happen. And then how to fairly tax for that, because
That's right. Yeah, that's part of the overall economic
Yeah.
impact
Yeah.
on the state that Milliman is gonna
Yeah.
be working with us on. But yeah, it's a great
yeah,
point.
like as a sole proprietor, I pay for transportation $600 a year, which seems a lot for
Yeah.
the amount I pay, and not having a business on the bus line, but as a home-based business.
Yeah.
But just things like that. But my other question is more, and we absolutely don't have to answer it today, but considering if we don't get waivers for Medicare or Medicaid, and considering that those populations are most vulnerable in terms of being who are disabled and elderly, and currently 50% of children in Oregon are on Medicaid, you know, how would we, thinking about how would we move forward, and kind of one of my core things is we don't want to create a two-tiered system. So like, I think that's somewhat in our values, but not called out that way, but that's like a concern that keeps coming up for me.
Go ahead, John.
I just have a clarifying questions. In your revenue estimation model, in terms of tax, is the unit of tax individual or household?
It's tax filer right now. So yeah, household. It would be probably the most comparable one.
Morgan, do you have any final comments?
No, I would just quickly to tie up. So much of the work that we're doing here is really to exploit a lot of the great work that the committee has done, particularly Charlie, who's going back to early part of end of last year and early part of this year to kind of dive into some of these pieces, and we've been working to do that. One of the things that's as we kind of now have some ideas of a base proposal, we're going to try to do much more refined modeling of household and employer impact, so we can understand. One of the key pieces of our work was really to say, okay, well, we understand generally businesses, but businesses aren't a monolith, right? We have different kinds of sectors, different kinds of sizes, and so we want to understand those things. And then I think, as Chen Wei pointed out, we have different kinds of households and individuals, and so we want to disaggregate that a little more to try to use a little more refined data. So here we're going to be reaching out and had some conversations with the LRO to use some of their potential information and data so that we can help supplement the work that's already done and dive down into these questions a little deeper. There are, I think, as many people have raised, there are questions around legality and some conceptual piece. So we have additional work there. And then these questions around plan design, cost containment, we have sort of additional coordination with those committees as well as with Milliman to make sure that the committees are talking to themselves in terms of our cost target and what our funding gaps may be, whether in our different alternatives for a plan, and so we want to make sure that we have that together. So, and then again, ultimately we have to sort of tie this up with information that's coming with sort of startup costs and transition, and making sure that we have understanding about how those pieces may be funded in more short range, as well as sort of making sure that there are adequate sort of reserves to operate the plan moving forward. So lots of work still to do, but I don't want to sort of minimize the fact that a lot of progress has been made over the whole course of this, and particularly over the time that I've been able to sort of support the committee. So I really appreciate all the grace and humility and thoughtfulness that the committee members have brought to the conversation, but particularly just helping us kind of kick off our training wheels and get up to speed with them.
Thank you, Morgan, so much. As one final piece of sort of direction to the Finance and Revenue Committee, I just want to reiterate that this board has said several times that our priority here is to come up with a revenue strategy that is politically feasible, that is equitable, that meets our values, even if we don't meet the funding gap. So our priority was to come up with a revenue strategy that you think best serves the state. And then we would adjust the benefits or the parameters of the plan to meet the revenue strategy. So we want the committee to come up with their best guess at what a good revenue strategy would be that is equitable and politically feasible, and then we can work to adjust the benefits from there. So I think it's now 10:45. It's time for a break. We're kind of behind schedule. So at this point, let's just take a break, come back at 10:55, and we can pick up from there. Thank you so much again, Morgan. It was a great presentation.
Thank you, everyone.
Do we know? Yes, doors and traps, right.
Cheryl may be needing to.
We are regathering now, just checking to see if we have Michelle and Cheryl back with us.
So Michelle, sorry, Cheryl is not going to be able to come back.
Oh,
So,
still one?
yes.
Yeah, we've got 5 here.
I know,
and
Michelle, I know. Okay.
Okay, great. Well, let us reconvene then. Before we launch into our next topic, we usually do this part at the end, but just while that discussion is still fresh in our minds, do any board members have topics that they would like us to work with our staff and consultants on to bring back for our next board meeting? Information that you feel like you need more, or sorry, topics that you feel like you need more information about, or things that we should include in future agendas to get more clarity on?
Related to what we just discussed now, it would be nice if they can compare. They need to do some estimation of, say, each income bracket, what they are currently paying
Yes.
for private insurance premium versus what under any scenario. I think that comparison will be very helpful.
Very important. Yeah, good. Yeah, I think that is another point. Yeah, thank you for calling that out. Anything else you'd like to hear more about to help us guide the committee and develop a revenue strategy?
I don't know. I feel like we kind of know what Echo Northwest, because they've jumped in and I'm on that committee. But I have no clue what we are asking Milliman to do or what they are proposing to do. Is there something I should be reading or background or somewhere, or is I don't know.
So that's a great question, and I can I'm trying to remember when Milliman is coming into which committee. They'll be coming to the operations committee, but they kind of have it, and PDD, so they have it broken down into a little bit. But I can recreate sort of an updated summary of the work that they're doing, and I would say that one of the there's sort of a couple of parallel processes. One is which they are definitely working on an administrative plan for the operations committee, and kind of using that. And then another very important task, and actually reached out to the All Fair All Claims team in Oregon to model again sort of the status quo. So in other words, we've been using the Milliman team, Echo Northwest team, and the committee, Finance and Revenue, have been using the data from the Optimus. And so this will be using more Oregon-specific data. From the data will be coming from 2023. So there will be an updated, as it were, sort of status quo, and from that we'll be able to extrapolate sort of like the differences if funding is, what the benefits will be et cetera, their increase, decrease, and all that. So that's a big component of the work they're doing. And then after all that is definitely the impact on Oregon as a whole, kind of like some of the things Amy was talking about. So if we shift this, who's going to leave their
Oh,
jobs?
so that is a Milliman thing, not an Echo Northwest.
Correct.
Okay.
Well, Echo Northwest is some of that more on the individual level, like, okay, this, but Milliman is
the
looking more
overall
at the
state
statewide.
economic
Correct.
thing.
Yeah.
Okay.
So
I wonder if as part of your executive director report next month, you could kind of encapsulate Milliman's role.
Absolutely.
That would be great.
Okay. And then my interest, I wonder if we can explore, I'm really interested in small businesses in Oregon. How many are there? How many of them are at that 150,000 payroll level? And how many are at that 300,000 payroll level? How many of them currently provide health insurance for their employees? And so what kind of tax impact are we going to have on small businesses if we, depending on which level we choose, and how that will go over? I think most businesses in Oregon are small businesses, and I don't know anything about that population of folks and how this plan would impact them. So,
I think that was definitely one of the things that Maureen had on his slide and things that they're tackling as well. But yes, absolutely.
One of the things that the committee, the reason that we went with the hundreds of thousands of dollars payroll to kind of say that's what a small business is, because we're trying to also again talk about avoiding cliffs, so that if we defined it by, some people define it by like 3 or more employees or something like that, but then people resist hiring a fourth,
I see.
that kind of thing. And if it were like 150,000 or 200,000, then that would be excluded and it'd only be on the $1,000 more. I mean, it's not like a cliff.
Completely.
And that's another big deal that the committee has talked about, avoiding cliffs.
Yeah, that's great.
And also on the small business thing, that I hadn't really thought about, like you can be like an individual lawyer for somebody that's paying yourself pretty well. And you are there versus an employer that has 3 employees that are paying them $25,000 each or something kind of thing. So I agree with you, Helen, we need some more data on who are these people and
how many
are they paying for health insurance for their people at home.
Any other topics the board wants to make sure we hear about?
Related to the revenue issue, but this probably more to the community engagement, is I've been sensing most Oregonians still don't have a good clue of we are doing implementing universal health plan. So we have a lot of work to do to not only publicize but communicate, and specifically, it will be helpful not too distant future, very quickly, ideally this year, to do some kind of survey that coupled with communication about what we are doing, what this universal health plan is for, versus what are the tax rate, particularly income tax rate, people feel acceptable.
Well, we can talk more during our report out, but our focus from our legislator and our budget does not include a broad public engagement campaign for the general public.
Yeah, so one of the things we talked about early on, which just as a reminder, is that yes, at some point we need to be having more communication and direct outreach. But I think people's natural question is, well, what does that mean? What is that going to mean for me? Is there going to be an impact or what? And we wouldn't have a plan to show them yet. And so our focus right now is to be coming up with a plan and making it as clear and specific as possible. And then in our next iteration of the board, which probably would not happen for 2 years, until after our legislative report, to start talking about it more publicly and getting people's feedback.
Yes, but my main point is about acceptable tax rate.
Acceptable.
Yes,
tax.
Before we
to get the
present,
feedback.
yes, exactly.
Feedback, yeah.
Before we present that, we need to have
Mhm.
some knowledge of what people are thinking.
Right.
Even still, though, they're gonna say, well, what would I get for it? If I would get a comprehensive set of benefits or a very limited set of benefits, would I still be paying, social security tax for Medicare? Would I, I think there'll still be some questions about, we need to show you, get this tax rate for these benefits, and we don't really have that defined yet. But yes, I take your point, like, trying to figure out what's feasible. in terms of that.
And I know that I keep hearing that from Amy and from Michelle that we don't have the money or the bandwidth to really do more than those groups that are defined in the law. But I'm wondering if there are, like Tony's seeing some things that he really believes we need to have and that we don't currently have in the work plan because we don't have the budget and the ability. Is that something that we want to take a look at projecting out? There is another legislative session that will be coming out in January. And should we be looking at that we need to say we need more or not? But that's
Michelle's hand is up.
question.
Yeah, we're always considering that. We always have an eye on what our deliverables are and what our budget is for that. Yeah, go ahead, Michelle.
Yeah, thanks, thanks, Helen, for that great summary. And also, I think that's a great question, Mary Lou. And I do believe it should be part of our recommendation to the legislature that, when they move this plan forward into implementation, that a first priority, a condition of success would be a robust outreach and communications plan to Oregonians. And I think that even if we had the funding today, presenting, like Helen just said really well, presenting something that is not, that hasn't been decided yet could do more harm than good. And then also, we don't know when the legislature is going to find it feasible to put this into implementation. And so if there is a gap, then I think doing that broad engagement when there's a final plan and we can answer all the questions people are going to have with clarity and it's sooner to when they will see the benefit. I think all of that is really important, the timing and having the specifics. And so on the Communications and Community Engagement Committee, we talk a lot about how one of our top priorities is to do no harm. That this really depends on the timing and the specifics. And so we're really focused on that. So we all agree that we need to do that broad engagement. And so, yeah, just wanted to offer those comments as well.
Thanks, Michelle. Any last topic ideas for future meetings on this topic of revenue strategy? Okay, then I'm going to hand it over to Lee to talk about regional entities.
Right, thank you. So we chatted about this a little bit last time. I'm here to just do a really quick review of kind of the status of things, sort of where we currently are, and really a chance for us as staff to get some feedback on remaining questions that you have, thoughts as we continue to move forward on this. So this is going to be a review for everyone, but I think we all know there are definitely benefits to having regional entities. The key one is to ensure that local priorities are being met, that there are folks that are really close to the ground, close to their community, really embedded there. Having this decentralizing can also help to make organizations more accountable because they are closer to the people that they are actually serving. Now, when we look at entities and, whether it's centralized or decentralized, we really find that there's these 4 categories of involvement that you see on the side. At the most decentralized, where something like a regional entity would basically be doing everything, we could call them responsible. Just below that, there's what I would term accountable, followed by advisory, and then at the broadest level, informative, where they are present, but most of it is being handled by the central agency or entity. Next slide. Again, some review, but I think always worth noting what the Joint Task Force has recommended in this area, since we are using their recommendations as the basis here. They recommended that these regional entities operate in partnership with a board, that they do convening and collaborating. And really the key word down here is advise with relation to coordination and delivery. Next slide. I apologize. I know I'm talking fast, but that's because we're my schedule. Now, what's interesting here is in their interim report, they actually lay out quite a bit of detail regarding how they feel responsibility should be split between the state and the various regional entities. So I'm going to start on the left side here with the state. There's a lot of responsibilities here, but they really fall under 4 broad categories. What they call financial management and stewardship, program administration, that would be doing health plan type things, claims administration, customer service, quality and data, so collecting all that quality, establishing what those quality measures are, collecting the data for it, and then program policies, so those overarching rules and regulations, how payments want to function, etc. On the left, we can see they designated certain functions to regional entities that include really advising that board regarding pretty much every single aspect there. They do also include, as part of the recommendation, managing a budget, but this is not a budget for payment so much as what I would term kind of a local budget, something that can be used to develop local initiatives, etc., based on what they feel the needs of that community are. Ongoing community and stakeholder engagement, promoting collaboration, and doing regional planning processes. So things such as the community health needs assessment could fall under there. Slide. Now, if we look at regional entities and what we kind of have today, the closest thing I would say are the coordinated care organizations, CCOs. And here is just sort of that broad division of labor. On the state side, the state is doing benefits, it's running a formulary, it's doing those quality measures, it's establishing overall global budgets, and it's managing compliance. Those coordinated care organizations, they are taking on financial risk. That's obviously a big one. They're doing a lot of the underlying health plan administrative tasks, networking, contracting, local advisory panel, social needs, sort of what I would consider a day-to-day functionality. Slide, please. So going back to those levels of involvement, what we really see is that those Medicaid CCOs are functioning in that accountable area. The state is providing an overarching framework. They're really handling the day-to-day of doing things. They are accountable to the state for putting things in place properly. And the Joint Task Force recommended something more in the advisory kind of zone. So the good news here is, as we're talking about regional entities, we can already narrow it down to these center 2 categories because there seems to be pretty strong consensus. This is where regional entities are going to be most effective. Next slide. So just to wrap it up, for your consideration, really I would say these are the 2 sides of a spectrum that we're asking you to think about. We've got on one side the Joint Task Force, where regional entities would be operating in an advisory-like capacity. The focus would really be on implementing local initiatives, staying in touch, and then raising those concerns up to a state entity. And then on the other side, what I have listed is option B, CCO-ish. This would be, not only are they advising whatever the state entity looks like, but they're taking on certain maybe health plan administrative functions, or maybe some more like budgetary managing functions. Now, I will note that as staff are considering this, we've heard from you all that financial risk is not something you're interested in regional entities taking on, which is why I call it CCO-ish, because we're taking that one off the table, at least for now, pending a change in conversation here. And, you know, pros and cons here. This one could leverage existing skills of organizations that have local infrastructure that have the ability to manage all this. On the flip side, when we look at something that's more advisory, the focus is solely on raising those community voices. So functioning a little bit less like a health plan. And there's no right or wrong here, but staff would just love to get your feedback, any questions that you have, ways that we can research this and bring more information back to you.
So one of my concerns with the current model is that we have CCOs that are for profit and have boards outside of Oregon. And so Oregon tax dollars leave Oregon. And so I think we just need to put that out there. I don't think we want to recreate that.
And yeah, I think I'll just leave it with that. And just whatever kind of community advisory thing, when we get to that level of detail, it's really important that it's goes beyond being performative and checking a box, whether it's community, but because as someone who's on a lot of communities with lived experience, it is insulting.
I have a few thoughts and suggestions. First is to what extent those regional entities should have in terms of their responsibility or level of delegation is also highly dependent on to what extent we are going to implement global budget. So for example, if our global budget will be extensive, not just hospital, but also clinic and other sectors, then the regional entity will be a heavier burden. So that's one thought. Second is, in terms of the nature of this regional entity, one option taken from Taiwan's experience is this regional entity can be a regional office of the universal healthcare, meaning it's government. It doesn't have to be private. That's an option, which Taiwan is doing that. And with that, they bear more responsibility, more accountability. For example, Oregon has very diverse community, particularly Central and East Oregon, very rural. And in Taiwan's experience, they allow those regional bureau, which is a government entity, to have flexibility within the structure of universal health care. They have flexibility of adapting to the local need in terms of how to deliver healthcare. The other issue is the regional entity in Taiwan's case, they are also responsible for auditing.
For what?
For auditing the claim from that region. And so the regional entity, depending on whether it's government or the local nonprofit, they can have a very different function. And I suggest we can explore having, we will have a central for the entire state, but then we may need regional office. And that regional office can serve as a regional entity.
And can I ask a question, Joanne? In that scenario where you have sort of let's call it a universal health plan regional office, would it also be possible to involve, for example, a third party to do some of the tasks, like claims processing or whatever, instead of potentially creating a structure and hiring an entire new workforce? So in other words, could it be a bit of a hybrid? I don't know if I'm explaining that very well.
Contract out with private providers for like things.
It could, but in Taiwan's case, it's all in-house.
All in-house.
Yeah, because Taiwan has a very sophisticated online system. The claim doesn't send to the regional. The claim is sent to the central office because it's a supercomputer.
Okay.
It's a supercomputer handling everything.
That's how you
Yeah. It's just when it comes to auditing, they delegate to the regional because those auditing are the provider in that region. But the claim they don't send to regional, they send to the central computer.
What's the population of that?
What was 23.5 million?
So the regions are.
6 divided into 6.
Right, like the size of Oregon, each region.
Each region about the size of Oregon, yes. But Oregon is about 7 times the size of Taiwan in terms of geography. Yeah, and so we have a huge rural area with sparsely populated population.
Michelle, did you have a question?
Thank you for this. These slides are really helpful. And in looking at these two options, option A and option B, I want to check an assumption that I'm making, in that if we didn't go with option A, we might struggle to realize the administrative cost savings that have been part of what makes this model work financially. Because if we stick with a CCO-ish, which I love that term, model, then it seems like we're stuck with the kind of fragmented, inefficient, duplicative, administrative. I don't even know if anyone would call it a system, but the reality that we have today, that I think most people agree is challenging. Is that not am I right in that assumption that that would be a reason to go with option A?
Not necessarily. I think like Chun-Wei was saying, like, you know, the level of account, like it could all still be administered at a state level, but just with sort of more local control and local input and sort of, it doesn't necessarily create another layer of bureaucracy between the delivery of services and the payment of services. It just kind of is a more local, responsive factor instead, because if we don't do that, then like in the cons for option A, we have to build out a whole lot of administrative structure at the state level, which we currently don't have. And so it's not necessarily simpler. I mean, I'm favoring option B, partly because in our cost containment discussions with plan design and expenditures, having some sort of global budgets and regional budgets is going to be our main strategy, I think, to contain costs. And that's really hard to do globally at a state level without creating inequities between rural and urban areas. And so when you have budgets that are based on a region, you can address regional needs better and account for differences in access to services and cost of services that happen at different regions. So you could tailor the payment that's specific to that region. Oregon operates really differently, as I know all of you know better than I do, in our rural areas and in our urban areas. And so being able to tailor how services are delivered and payments are made to the region is really critical. So it's not necessarily creating more complexity to go with B. I think there's pros and cons to both.
So,
Go ahead.
Oh, no, go ahead, Michelle, please continue.
sorry, just a follow-up question then. So kind of piggybacking on Mimi's idea of a hybrid, I guess when I saw option A, that the role would be, you know, to focus on regions, regional needs, I thought that that was part of what was happening. But what I think I hear you saying, Helen, is that without having some plan administrative functions, that's actually hard to put into it, hard to implement, hard to address those needs other than just advising to the state. So is there two questions? One, could we bring this back with a hybrid, something that looks like a hybrid between bringing the best of both of these models and trying to incorporate them? And or do we have a strategy, or would a next step be coming up with a strategy to make sure that we are avoiding the pitfalls like the inefficiencies in having every CCO have its own administrative systems, and as Amy said, some for-profit, some nonprofit, et cetera, et cetera.
Right. So I think of both A and B as able to assess community needs, but B having the power to do something about it because they have control of the budget. Whereas A, they're just advising the state, we think we need this, and the state can take it or leave it. Whereas in B, the region actually has the power to make the changes that they see. But I totally hear what you're saying about efficiencies. We certainly don't want to create inefficiencies, and streamlining how the care delivery and payment happens is a huge priority. And so we certainly would keep that in mind. But yeah, I think we can work on sort of sketching out exactly what that would look like. Yeah. Go ahead, Judy. Mary, sorry. I wasn't paying attention first.
I guess I'm interested in, and maybe this because I come from a governmental kind of mindset. I personally would like to know more about the regional offices of the plan. I remember back to a former, may he rest in peace, John Lee, CEO of Providence Health System years back, and he and I were doing something, and then on the way to where we were going and driving in the car, he looked and goes, "Mary Lou," I was at Multnomah County at the time, "Are you centralizing or decentralizing?" I said, "I think we're centralizing." He goes, "We're decentralizing." I mean, there is no perfect way to have central, decentral, et cetera. And our organizations over the years that I've watched go back and forth between these. And I think we're looking for something in between.
Because they're possible.
Yeah. So anyway, just a.
I'm just wondering, I see the note on like CCOs for regions would not take on risk. I'm wondering if there's a benefit in splitting out the kinds of risk. So maybe they're not on the hook for downside risk, but maybe there's some upside benefit. Like, and specifically regions can set or customize incentive-based structures for clinician performance, especially so I'm thinking about. That's in alignment with what the state outcome measures are, but specific to that region. So the regions could benefit from incentive payments without having to be on the hook for another consideration.
If I could just make a comment on that, I think, and this, of course, is all very much in shorthand. Absolutely, that is a potential for the providers, like you said, to take on upside risk. I think what specifically was being called out is that there would not be another completely outside organization, another health plan, as it were, that would come in and if it were taking risk, could also take profits. So that's where that comes in. But I think as we flesh it out, absolutely. And I think, as we've said, risk is, there are all different kinds of risk that we're talking about. And so as we build out the model, making it clear specifically who is taking risk or what reason. So thank you, though. I think that's another good thing for us to think back as we build policy.
And we wouldn't, I'm sorry, have, like right now, with our CCO model, where we have, you know, multiple CCOs in multiple regions.
Right.
Taking over each other's, you know, like all the things that are happening now, you know. Right.
Yeah, we have a lot different. Yeah, and it would, oh, I apologize. I was just wanted to remind people kind of a couple of meetings ago, I think, talking about like the geographic footprint of the region. So there's no, even though, again, CCO is super helpful, that doesn't mean it would be the same geographic footprint that exists now. And it definitely doesn't mean that there would be overlap. You all have input into it.
Yeah. So we're definitely keeping this on the agenda for future meetings. And my understanding, correct me if I'm wrong, is that I think staff might be able to give us a couple of proposals by September meeting for what regional entities could do. So thank you for your feedback on that. And this will be a continuing.
Just one more
Yes.
comment. In an official capacity, the regional office in Taiwan, they also address or handle the eligibility.
Yeah. Yeah, that was really important. Yeah.
And that's also have a physical presence in each region. And so people don't have to always come to Salem or.
Yeah. Exactly. Okay, let's move on. We got to do some committee updates and we're a little short on time, but I'll pass it to community engagement and communications first.
All right. So I'll start, and Michelle, you can. So we now have Patty Lentz is now on board as our communications contractor. So we've made a lot of strong progress making up for time. The committee has been actively reviewing draft materials, and in September we'll be bringing forward draft proposals for a work plan and communications plan. 2 one-pagers describing the board's work, one detailed and one in very simple language, a strategic messaging guide, and updated mission language. And looking ahead, we're working on an FAQ, frequently asked questions, a finalized style guide, updated website copy, and new presentation slides aligned with the messaging guide. And to take out when board members, you know, present. A meeting is also being scheduled with both of our contractors, Patty Lentz and Diana Bianco, as we bring Diana back on for the community engagement, as we wrap up for that, along with me and Michelle and I to review the updated work plan and timelines in preparation for the engagement planning. And we don't have any questions or strong proposals this month.
Okay, great. Just as a heads up, the staff and Judy and I are working on the content of the PowerPoint right now. So I would hold off on having Patty do any work on that for now. We're going to update the content so it's a little bit more up to date and accurate, and then we can pass that to you. Of the PowerPoint.
For strategic.
Yes.
Take it. Okay.
Yeah. Okay. Yeah, so don't work on the one that's currently.
Okay, we'll wait. All right. Makes sense.
Cool. Finance and revenue.
So Cheryl had to sign off, and essentially you heard what finance and revenue was working on with Morgan, and then just the addition that the Millen team and working on the cost targets and the gap. Unless Mary Lou, if there's anything else I left out.
No. Do you anticipate that finance and revenue would have a revenue proposal as soon as September, or are we looking at October, November?
Oh, I think they'll have one by September. That's a
It's
proposal.
August. This is August.
I know, they're meeting every 2 weeks.
Okay, I'm more pessimistic. I think October sounds very reasonable, but
Great. Be a proposal.
all right.
Okay, So plan design, we have been spending a lot of time talking about provider payment strategies, and our committee has still largely focused our conversation on paying primary care. And we do have a straw proposal that I want to present to the board. You'll have it in your packets. Going over that will be our primary objective. And then in the future, we will be circling back on some eligibility and benefit questions and talking about payments to hospitals and to specialists. So in terms of the straw proposal, the PD&E committee recommends that the Universal Health Plan reimburse primary care providers using the primary care value-based payment model as developed by the Primary Care Payment Reform Collaborative. And the committee further recommends that 15% of UHP expenditures be allocated to primary care. There will be a couple of key dependencies for this proposal, mostly depending on the administrative structure, as we're just talking about in terms of the role of the regional entities, how contracting and payments will work, and then the total plan cost. So we are dependent on those to officially formalize this. That will alter how these payments happen. But as by way of background, the patient-centered primary care home model was established in Oregon by our legislature in 2009. And right now, more than 600 PCPCHs exist in Oregon, representing 75% of all primary care practices. The total healthcare expenditures have been reduced 6.3% by the PCPCH model. And we've also found that every dollar that we invest in primary care saves $12. Primary care, PCPCH patients use more primary care, and they use more specialty care, and they use fewer emergency department and inpatient services. That's where the savings come from. So as I said, that model has been in existence for several decades now. And to build on the model, the legislature created a primary care payment reform collaborative in 2017. So for the past 8 years, that's a group of payers and providers who've been working together to consider the optimal way that primary care should be paid based on their ability to deliver these high quality services. Up to date, there's been limited uptake of the model. CCOs are required to implement it, to adopt it, but other payers have been reluctant to adopt the model due to fragmentation and competition. So, clinics have multiple payers that they work with, payers are competing with other payers, and it's been challenging to get them to take it up. But basically, the model encompasses 4 payment strategies, which can be adjusted and negotiated for every primary care practice, depending on their capacity. So the first is prospective capitated payments for a defined set of primary care services. The ideal is that most of what they do would be paid for on a prospective capitated basis. There would be fee-for-service payments for all other covered services. And then there are some infrastructure payments that are done as a per member per month, including a base payment tied to the tier of PCPCH that they're in. You can advance along a progression of 5 tiers, depending on your ability to coordinate care and deliver higher quality services. And then the 4th group of payments is performance-based incentive payments that address quality. So as I said, practices can negotiate the proportion of their payments that fall into each of those groups. And so it allows some flexibility for practices that are more capable of taking on risk and less capable of taking on risk. Practices that already have well-developed infrastructure like data collection tools and care coordination, and practices that are less advanced in that. So it allows some flexibility there and ability for practices to increase their payments as they progress along that tier. In addition to the base model developed by the collaborative, the committee felt pretty strongly about calling out care coordination and care management efforts. This would technically fall under the number 3 in the payment models, the infrastructure payments. It's not specifically called out in that model, but our committee felt like that was a key component of the PCPCH ability to deliver high quality, lower cost care. And so we wanted to highlight that and call that out specifically. In addition, we talked about having practices have the ability to opt out of the model. For instance, if primary care was part of a multi-specialty clinic, or if it was a primary care practice that was owned by a hospital, they might want to opt out of this model because they've already had other payment arrangements. Briefly about the payment allocation of 15%. On page 5 of the proposal, it talks about, we've had a goal of 12% allocation to primary care for several years now. Most of our payers are already reaching or exceeding that goal. There's a bar chart on page 6 that shows that Medicaid already is at the 15% level. CCOs already pay that they allocate about 15% of the resources to primary care. And then Medicare Advantage is at 13.9%, OEB at 13, and then PEB and commercial are around 11.5%. And so 12% seems easily obtainable, and we know that more investment in primary care will save us money. And so the committee opted for a target allocation of 15% of all UHP resources to primary care. Sorry, that was a lot. You have lots of questions on that?
Just quickly, I want to give props to the committee to design something around a model that already exists and is working in Oregon, because the transition to that is seamless, right? We already know it works. And the call out for folks who are unfamiliar with PCPCH is we're paying for quality, and that's huge. I don't think that should go understated.
Yes.
How will that model impact, I guess a couple of questions, like, do we have enough PCPs to invite the entire state into that model? And how will that impact patient choice?
So right now, 75% of all practices are PCPCHs.
Okay.
And yeah, so more than 600 practices are. So I think there's already very good adoption of that. I can't imagine how it would impact patient choice at all.
Because on Medicaid, in the current model, it does limit choice. I know people with disabled children who have found, say, mental health therapists that are in the community and have a therapeutic relationship for people with very complex challenges. And so they get calls from the county behavioral health every 6 months trying to force them back into that system.
Okay.
So like,
Yeah, so I think that has to do with networks that are available based on payers. And in the system, there wouldn't be a network because there's a single payer.
so
Right.
there wouldn't be that kind
Yeah.
of trying to
Yeah, that's the idea. Yeah.
contain.
I guess my question then is, I'm just having a conceptual problem with 4 million people and networks or not networks, or how does it work? I mean, would people be able to choose their PCP? Okay, and then if they've chosen Dr. So-and-so or nurse practitioner so-and-so, then that person takes responsibility for that member.
Right.
And then, but it's not like the current system where you have to choose, this CCO that has this network or this insurance company that has that network. I'm just trying to figure this.
So there's no more networks, but we know that quality care delivery depends on the ability to coordinate care between primary care and specialty care and inpatient services. And so on some level, some sort of attribution, some sort of population that you're managing is really a useful thing in primary care to say, these are our primary care folks that we coordinate care for. Now, folks can choose to go somewhere else if they want, but that limits our ability to manage costs and manage quality when people travel around and access services. It's also very redundant oftentimes because things get repeated, but people can choose to do that. It's just on some level, we try to encourage picking a primary care provider and staying there if it's working for you. We're not going to hold anybody to that. We can't require that, but the more that happens, then the more we can control costs and quality.
I don't disagree with that at all. It's just, I'm trying to figure out the kind of the practicalities of this. And I just keep thinking that I keep talking to people who are saying they can't get a primary care appointment for 6 months.
So that's a different problem. That's a different problem. So there's the network problem, which will go away. There's the workforce problem, which is a very different problem.
Yeah.
We currently, right now in Oregon, do not have enough primary care providers to serve everyone in our state, and we'd be bringing on 200 to 400,000 more people onto health insurance.
And we're trying to figure out incentives for providers to come, just kind of like the Canadian
Right.
effort is going right now to get people to move to Canada, providers to come to Canada. So we're going to try to be getting providers to come to Oregon because we have this great plan and it's simpler and it's better and all of that.
Right, and I will say as a primary care provider who has left the provision of primary care, part of that is because there's so much demand on primary care providers to do so much without enough support. And the reason why we picked the collaborative model is that it provides payments to primary care providers so that they are supported in the work that they're expected to do and paid for more than just, you know, counting visits and counting services. They're paid for all the other back of the office work that they do to coordinate care and deliver quality. So the idea would be they would be paid better, and therefore we retain them more, maybe draw more people. We need a bigger.
I agree for sure. I wish Bruce Goldberg were here today, having been a primary care provider, et cetera, to hear, you know, he's got more experience. So you and me
And Judy,
yeah.
I'm working to train him.
yeah.
So
I'm wondering if, since we have Janine Smith, who's one of the persons who originated the Patient Centered Primary Care Home, Janine, and also worked a lot on this, helped us a lot with this proposal. Janine, are there any things that you would add to the discussion or around this?
Let me, thanks, Mimi. No, I only thing I think is to, in response to Mary Lou's questions.
I can't hear you.
Oops, hold on.
Can we make her louder?
Let me,
Okay.
can you hear
We
me
can
now?
hear you, but it was very faint.
Better?
Oh, yes.
That's
Yes.
better.
Okay, sorry. I think, you know, this proposal just continues to support the work that's been going on now from, hard to believe it's been almost 20 years, of PCPCHs, so that they can support that team-based care inside the clinics. They're not necessarily have to be assigned. I think that's up for further discussion, but without those additional infrastructure, PMPM, kind of payments, it sort of undermines their whole team-based model. And we've also not always well supported primary care in our payment rates to begin with. And we know that that keeps people out of the emergency room and out of the hospital, which is why that $1 in a PCPCH spent, it results in $12 savings. That's documented recently by Dr. Wallace at Portland State University in using the all payer, all claims database to prove that. So, and as an advisor to the PCPCH program lately, that you really see this all over the state. Rural clinics are doing this as well as urban clinics, and it really has been supportive to these practices to help increase access to care at the same time by having this sort of team helping take care of the patient, instead of it being like when I was in private practice where it was me and my medical assistant against the world. So I do think that this is a nice way to continue to support the primary care program. I think as operations starts to think about administration, as you think further about the regional approach, this is just a suggested means on which to pay the primary care providers.
Any other thoughts or questions about the proposal? So in order to just capture the committee priorities a little better, I would propose just editing in the straw proposal when it discusses the value-based payment model for primary care under number 3, where it's infrastructure per member per month payments that include 1 base payment tied to PCPH peer, and 2 additional payments for specific high value services. We wanted to call out there, it would say additional payments for specific high value services, particularly care coordination. Just adding that phrase in there to highlight it and call it out. And then on page 4, where it's at the end of that value-based model description, it says, while the model will obtain broad support, after that paragraph, after that last paragraph, I would put in a statement saying that practices may choose to opt out of the collaborative payment model if they have already made other arrangements such as full capitation as part of a multi-specialty group, or if they're owned by a hospital, I would just add a opt-out line in there.
And where was that at, Helen? I'm sorry.
So page 4, most of the page is the discussion of the value-based payment model for primary care. And the last paragraph starts while the model will change. After that last paragraph, just a single statement that says practices may choose to opt out of the model if they are part of another payment arrangement as part of a multi-specialty group or a hospital-based practice. There are some practices that are already fully capitated that don't need the support of that the model is offering to bring practices along, or if they're part of a multi-specialty group, it would be hard to pull out the primary care practice from a big multi-specialty group and pay them differently than the rest of the group. So I think we need a specific opt-out there for those practices.
But that's assuming that in our model, we would have a fully capitated.
We do.
Whatever, and I don't know.
I
that
do.
we agreed to that.
What's that?
I don't know that we, in our payment stuff, I don't know that you've set that out as part of.
So this is how we're paying primary care, and there's an option to be partially capitated or then fully capitated. So this proposal says how the plan wants to pay providers is going to be based on this model. And this model allows for partial capitation, PMPM payments, and for sort of progressing people along a risk-bearing model as much as they feel able to do that and willing to do that. And there are some practices that already are fully capitated and would like to remain so, and that's how they want to be paid. And so it would be an option to continue that for them.
I'm ambivalent. And I helped set this up years ago with Eric and all of that. So I'm just nervous a bit about the administrative costs on both ends at the state level, you know, so I won't vote against it, but I just guess I want to say that it's, you know, kind of like, okay, this, and I didn't have time to listen to the whole committee meeting that kind of came with this. It just, I guess I had been thinking more, and I know the downsides of fee-for-service, but a higher fee-for-service payment that allowed practices to do what you're talking about without kind of this managed care capitation feeling to it. I'm just.
Yeah, so the collaborative has done great work over the past 8 years to talk about how best to pay primary care providers, what would best support their work, and fee-for-service doesn't support the work to coordinate care and deliver high quality. It just doesn't. And so primary care providers are asked to do a whole lot of things other than see a person for a visit and get paid for that visit. And so in order to compensate them for the other care that they provide, besides that direct face-to-face office visit, this model was created as a way of supporting primary care and delivering higher quality. And so we're just taking the model that's already been developed, proven to work, proven to save money and deliver higher quality care, and already in use across our state. Every CCO is required to do this because it saves money. So we would just be expanding that to the rest of the state, and people can participate in terms of capitation at the rate that they are able and willing to do so, and they would be supported by that. That would be one of the administrative roles, potentially of regional entities, is to support practices if they want to advance along the model. If practices want to be fully fee-for-service, that's a possibility too. So that would be an option for them, but it's giving practices the option for that.
I'd like to ask Dr. Chi, what is this, something like this in the Taiwan model or not? Or?
It's partial because Taiwan has been trying to establish a primary care model, but so far hasn't been successful. But as I mentioned, the regional office has experimenting primary care model. One of the region started experimenting.
And they do some value-based payment and some fee-for-service.
Yes.
Yeah, they combine it.
Thank you.
Any other thoughts or questions on the proposal? When we vote on our proposals, just the board sort of giving the go-ahead to the committee to kind of, yes, we see this direction that you're going and we endorse it. And so approving this straw proposal doesn't mean that this is final by any way. It's just another sort of step in the process of, toward, at the end, we'll have to reconcile with our revenue strategy and with our administrative structure, like I said, but is there a motion now to adopt this as a straw proposal for payment of primary care providers?
Chair, I move to adopt this as a straw proposal for payment of primary care providers as presented.
Second.
Any further discussion about it? Okay, let's do a roll call vote.
Ellen Wonka,
Yes.
Sean Wei Chi,
Yes.
Amy Fellows, yes. Michelle Glass,
Yes.
Bruce Goldberg is absent, Judy Richardson.
Yes.
Joe Ramirez is absent, Mary Lou Heinrich.
Yes.
Excellent. And then we have one more committee update from operations.
So our next meeting is on August 28th. Otherwise, I don't have an update.
Okay, great. We're a little out of time for the federal.
I think there are three people to speak online
Yes.
too, so.
Yes, do you have any federal state health policy updates, or can we defer that till next month? We defer it? Okay, we'll defer that to next month. And then quickly, in terms of next steps, board outreach, Judy and I were invited to give a presentation next month to the OHSU alumni organization, and so we're working on our presentation for that. Anyone else have invitations or presentations coming up?
It's at noon. I am going to be just kind of a backup to actually Valdez Bravo from Healthcare for All, speaking to the Coalition of Local Health Officials.
Okay,
Kind of trying to let counties and kind of know what we're up to, so.
great.
But I'm going to sign off and we'll do that.
So we have the standard PowerPoint and standard talking points,
Mhm.
and so we ask all board members when they do presentations to use those. We can connect you with staff.
Well, since really
he's-
Valdez is doing this, I'm just kind of,
Oh, you're the backup.
I'm backup. I'm not, so it's really his presentation.
Okay,
And I'm sure actually it's fairly short on their agenda, so I don't think it's a long kind of presentation. Kind of letting them know that this is going on, because as we're saying, a lot of people don't even have a clue.
right.
I also has an invitation by Taiwan's equivalent of NIH, Nature Health Research Institute. This year is their 30th anniversary. So they organized an international conference. And they invited me to talk about the future of universal healthcare, not on specific countries, but in general. And I will briefly introduce our effort.
Oh, that's awesome. That's great. International. Great. Any other presentations, invitations?
I'm just talking to my MBA students.
Oh, yes. And then we talked about future meeting topics regarding the revenue strategy. Any other future meeting topics that we can present to staff to bring up? Anything about regional entities or anything else? You'd like
And
to
we
speak
captured
to?
that we're bringing
Communications folks.
in September, that we're bringing things to the.
I just want to make sure you're doing a board presentation in September.
Yes.
Absolutely.
Okay, we got
Just
that.
in general, does the board members have any topics they would like the staff to research or bring
Oh,
back to
okay.
the board for our information? Drop the hooks. Plenty on the revenue plan. Okay, great. So now we'll move to public comment. We have 3 people for public comment. We have 8 minutes left. We'll ask all of our public commenters to please limit your remarks to 2 minutes. Yes, and we can start with the person in the room. Sorry.
May I come to the table so I can?
Yes. Come on up. Sorry, we don't have your name or sorry, can you tell us your name?
Oh, I'm going to speak to the mic. Michael Huntington, MD, retired radiation oncologist from Port Allis.
And the founder and first president of HCL.
So I'd like to start with a thank you for your thought and time that you've invested over the past 18 months. In the current political atmosphere, you wonder, why are you doing this? 35 years ago in another country, living under an autocratic rule, there were people like you planning how their country would provide healthcare for everyone. They must have suspected that the window would open. They didn't know when. It did in 1995. They did not know how long the window would be open. They had to be ready, and they were. Your work is getting us ready. A little good news. Yesterday at Senator Wyden's town hall in Philomath, I raised a question about the Senate Bill 2286, the State-Based Universal Health Care Act. He responded enthusiastically. First time ever, he responded well about anything related to universal health care. So he plans to meet with Valdez, and I hope to be there, and maybe someone from business to talk with him and his staff about this. The tax increase of the population above 500,000 is going to scare some neurosurgeons. You have to think about that. Partial single payer, we need everybody in if it's going to work. No on the CCO model, it's capitation, it's expensive value-based systems. Not so sure that CCO model has actually saved us money. Connecticut resumed control of Medicaid and saved 14%, agree with global budgets for all care, not just hospitals, and agree with the board having oversight of appointees to committees. Thank you.
Thanks, Dr. Martin.
Oh, the mic. It's hard to hear people unless they're talking at the mic, and people tend to talk to the chair.
Oh, thank you so much.
Can you put a mic right there?
Oh, that's a great idea. Thank you.
Yes, thank you.
Good point. Great. So next we have Lou Sinninger.
Lou, are you with us?
Okay, then we're going to go on to Linda Krieger. Please apologize. I'm so sorry about your last name. Linda, please tell us how to pronounce your name.
Oh, here it is. I found it. Can you hear me now?
Okay, yeah, go ahead, Lou.
Okay, thank you. Jeez. Well, first of all, I'm having a terrible time hearing everybody. It's so echoey, and unless you're talking directly somehow, I'm catching every other word at best. Also, we can't see when you're looking at your papers and changing language, we can't see what you're looking at. Thirdly, the main thing I wanted to talk about was regional. What defines a region? And when you define it, some people are going to be in a region or out of a region. What does that do to, how does that impact the choice of care providers? What about the administrative costs? Are we setting up another big bureaucracy? Remember, in my mind, every payment plan will go into, every service will go into a centralized area. The data that we have available, the amount that we can control now is phenomenal. So doesn't it seem like it'd be a good idea to have that data centralized and be able to tell what the needs are of any specific person or clinic or hospital? Please, are you going to build, is it going to be a brick and mortar administrative thing? Why not stick to advisory? Advisory can collect the complaints, right? If you start administration, that's going to create another brick in the wall. Thank you.
Thanks, Lou. Okay, Linda, you're up. Please let us know how to say your name. Yeah.
Yes, thank you very much. My name is Linda Krieger. You can't hear me?
Now we can.
Okay. My name is Linda Krieger. It rhymes with tiger. I should always put that in when I print my name. And thank you for giving me the opportunity to make a public comment. I did submit written comment as well, and you did characterize that very well at the beginning. Thank you. For purposes of my public comment today, I want to go back to, and I know Morgan's no longer on the call, and I think he's going to reach out to me directly, but I'm very concerned about those graphs that were shown on behalf of the Finance and Revenue Committee. Michelle asked specifically, was the individual contribution shown, the additional individual contribution shown net of what people are contributing today to their health care? And I don't believe Morgan directly responded to that question. And it's very clear to me that it does not net that out. It does net out what we're currently paying in income taxes, but does not net out what we're currently paying in premiums, out-of-pocket expenses, et cetera, which would actually show most people would pay less and only very few people would end up paying more. And I think that's a really important point. The graphs are out there for the public to look at. I'm concerned about what kind of preconceived ideas people will start to get, and that they will be against this, even though most people in, I know there was a poll done several years ago that most people would pay double what they're paying in income tax today in order to get basically their insurance or their health care paid for by a public entity. So that's what I wanted to emphasize in my public comments. Thank you.
Thank you so much, Linda. Great. Okay, we have a minute for reflection. Judy was
Great. Thank you. Go to the next slide. And thanks to staff for finding the attribution for this quote. I know it's a common quote, and sometimes common quotes can seem trite, but I felt appropriate that we cannot direct the wind, but we can adjust the sails. And work on.
Thank you so much. Great. And as a final note, staff and Judy and I are conducting a 90-day evaluation of Mimi, our new executive director. And so I sent out an email to all the board members about this. But if you are interested in providing feedback and comments, please send those to Judy and I. Do not reply to all. Just send them to Judy or I. We'll be doing that next week. So just as a reminder for that. And thank you all very much for your attendance and your participation. And we'll see you in September. And I have to remember.